Good morning, everyone. I'd like to welcome you for coming to our symposium for melanoma, and this is in conjunction with the AIM at Melanoma group. So thank you very much for joining us. My name is Leslie Fescher. I'm a professor of medical oncology and dermatology at the University of Michigan, and we have quite a lineup of guest speakers to introduce you to some of our newer faculty at the University of Michigan, as well as provide hopefully opportunities for education and learning. I'd like to introduce Ann Garst-Taylor with the AIM at Melanoma group for just a few remarks regarding information of the question and answer session.
Good morning, everyone. So glad to be in Michigan. It's so nice and chilly here. As Dr. Fescher said, I'm Ann Garst-Taylor. I'm with AIM at Melanoma. I'm their Director of Community Engagement, and I'm going to have an opportunity later on to tell you a bit more about AIM. But what I wanted to do now is first start by thanking Dr. Fescher for leading the charge and working with us to co-host today's symposium with the University of Michigan, and of course to all of our wonderful panelists for their collective wisdom. We know that you are going to have questions today, and so because of that, we have 2 question and answer periods planned. There are several ways that you can ask those questions. If you are here in the room with us, then what you'll be able to do, if you look inside the patient packet that we've given you, there is an agenda, but also there should be a pad in there, and we had pens. If we didn't give you a pen, we'll just raise your hand and we'll get one to you. But if you'll write your questions down, then I have a volunteer, Suzanne. She's not in the room quite yet, but she will. You can raise your hand and she'll get your question. We'll get it up to Dr. Fescher. We'll get those answered during the Q&A questions. However, if you're one of the nearly 100 and some people that are joining us via Zoom and Facebook and YouTube, we want to say welcome to you. And you also can ask questions today. And the way that you will do that is if you are joining us via Zoom, if you look at the bottom of your screen, you'll see a tab down there that says Q&A. That's where you're going to put your questions, and then we'll be able to get those to our panelists. And then if you are joining us via Facebook or YouTube, you can just put your questions into the comment section, and then we'll copy them over into Zoom. And so that's all from me now. And with that, I'll turn the podium back over to Dr. Fescher.
Thank you, Ann. I appreciate that very much. All right, so we're going to get started with a brief overview of the concept of treatment after PD-1 inhibitor therapy. And these are my disclosures. I always like to start with definitions to make sure we're all talking about the same thing. So first and foremost, we're going to start with immunotherapy, the concept of medicines of a variety of different types to help a patient's immune system fight off cancer. And obviously we're talking about melanoma today, but this is relevant to lots of different kinds of cancers. I like this schematic because I think it's not too detailed. So I want you to think about our APC stands for antigen presenting cells, antigens, little bits of markers, if you will, to help educate the immune system of what to do. We have our cancer cells, and we think of this PD-L1 being expressed on cancer cells. And we have these anti-PD-1 antibodies that we're going to talk about. So this is PD-L1 antibodies. We also have anti-PD-1, and a lot of you are familiar with nivolumab or Opdivo, as well as pembrolizumab or Keytruda. And then we have this other marker, CTLA-4, which is on CD4 cells. And we think of things like ipilimumab or Yervoy. And the whole concept is that we want to try and block some of these so that we can then cause an activation of cytotoxic T cells and kill the tumor. And if we don't have those blocking antibodies, they can engage and kind of exhaust our immune system, if you will. So checkpoint inhibitors are a type of immunotherapy, and this is the majority of the ones we're talking about that we just said. There are brakes on the immune system. We like to think of like a car, brakes and gas pedals. So CTLA-4, PD-1, and LAG-3 are the most common ones you're going to be hearing about based on FDA-approved agents. And PD-1 inhibitors, CTLA-4 inhibitors, and LAG-3 are exactly what we just talked about. Other definitions, PD-1 naive. This is a person who's never received any kind of treatment with a PD-1 inhibitor. So specifically, we're in the melanoma space, we're likely talking about nivolumab, or pembrolizumab. And this would be at any time in the course of melanoma. What does PD-1 resistance mean? Well, one, we think of either primary from the beginning or innate, where somebody is treated with a PD-1 inhibitor and they do not receive any benefit clinically. And clinically, this could be shrinkage of the tumor or improvement of symptoms related to cancer, such as pain, after at least 6 weeks of treatment. With immunotherapies, we need to give enough time to actually potentially see that benefit, and that's the tricky part. Or we could have growth of cancer or stable cancer for less than 6 months. Secondary or acquired resistance tends to happen after you have an initial response to immunotherapy, specifically PD-1, where you have either stable cancer for more than 6 months or you have some kind of tumor shrinkage, and then later the tumors start growing. And then we have people who don't fit into either one of these categories exactly. There's some caveats and limitations to this kind of label, if you will. One, this doesn't account for tumor flare or pseudoprogression. Many of you have heard us talk about this, where when we think about immune systems and immune cells going into tumors, sometimes those tumors can get larger. Sometimes you can see new tumors that may not actually be new, but were kind of there and now are more obvious. And one of the big questions is, are they going to keep getting bigger, or are they actually going to decrease in size? So increase in size doesn't always mean increase in cancer. It can mean increase in inflammatory response. So that's hard to try and figure out what's going on sometimes for a period of time. The definitions that I just gave you are based on treatment with only a single monotherapy or the PD-1 inhibitor alone. This doesn't really, we don't have specific guidance of how do we use these terms when people have been getting combination therapy, such as Ipi with Nivo or relatlimab with Nivo. And this doesn't include patients who have had side effects and then have to stop or hold their immunotherapy temporarily, and then they start growing. That falls into a different category. Next thing, what does it mean to be after PD-1? Are they still receiving treatment with PD-1? Have they stopped treatment? What kind of context was it given in? Is this in the neoadjuvant or adjuvant setting? And I'm going to just say I have the luxury of having all of my speakers follow me. So you're going to get more and more details about a lot of these concepts as we keep going through the morning. Was it the advanced metastatic setting? Was it single PD-1 inhibitor or combination therapy? And if they stopped treatment, why did they stop treatment? And this goes to kind of figuring out what we do next. Was the cancer controlled and that's why they stopped the treatment? Was the cancer worse and that's why we decided to stop the treatment? Or was it for side effects? If still on treatment, where are we? Is it early on, or has it been going on for about a year and a half, or any time frame? Again, is it combination or single agent, and did it switch? And how much worsening? Is it one tumor? Is it a couple tumors? Is it a lot of tumors? Is it all the tumors? The next question I asked myself is, well, if we could figure this out, do we think there was any benefit to the PD-1 inhibitor alone? So I'm going to give some examples. You have a person with advanced melanoma. They were treated with combination Ipi-Nivo, and they achieved a complete response, meaning the tumors on the scans we could not see anymore, and we couldn't see them on physical exam. And we stopped treatment by choice because we thought we had given enough, they had achieved their benefit. And then 5 years later, melanoma comes back. That can't be removed with surgery, meaning we need to do more medicine. That person is somebody who clearly benefited. Even though they've had a recurrence of their melanoma, they had complete response and they got 5 years off of treatment without a problem. So that's something that I would consider additional immunotherapy in. I'm going to be honest, I'm going to be a little bit vague in the comments because, again, there's a lot of details that would go into what immunotherapy, how we would do it, and who knows what's going to happen as we keep going, right? We hope to have continued evolution of new treatments. A next example would be somebody with advanced melanoma who's treated with nivolumab. I'm going to give you a single agent option, an example. And they've had worsening of cancer, and not just worsening on the scans, but they don't feel good. That always worries us at the same time when the scans look worse and somebody feels worse, and we think that's tied to the tumors themselves. And this is after just the initial 2 to 3 months of treatment. It's concerning that this person is probably not benefiting from PD-1 therapy, and probably we should consider a change in treatment. And this is kind of an example of primary resistance. They're not getting benefit from the get-go. Third example, person with advanced melanoma, and we're going to say they're getting combination therapy, but with nivolumab and relatlimab, or Opdualag is the brand name. And they've had some initial tumor shrinkage, what we call a partial response. Those tumors still there, but they shrank by a certain degree, and that's on scans and their physical exam. But now they've been on for about 18 months, about a year and a half, and now you have multiple tumors, not one, but multiple, kind of growing, but growing slowly. This person probably got benefit out of it, or we wouldn't have been on treatment for 18 months with the initial shrinkage, but now we're having growth. So we think of changing the regimen in some way, and we got to think about how are we going to change it. And this is an example of secondary resistance, right? They initially got benefit, but now we're losing some of that benefit. So as I do this, I think about a couple different people involved or entities involved in this decision. I think about the person. What is their overall general health? Are they a little delicate? Are they really robust and healthy? Are you up and around half of the day? Are you eating, drinking, feeling good, doing things? Or are you resting most of the day and having a hard time doing kind of the basics? Are there other medical issues separate from the cancer that might factor into our decision-making for treatment options? That could include autoimmune conditions. I'm sure all of you are familiar with that. That is a part of the assessment process when we think of immunotherapies. Do they have things like liver or kidney problems as well? And there's obviously a laundry list. How did they tolerate PD-1? Was this a really tough treatment on them where even with a single medicine, they had lots of side effects? Or did they do pretty well and kind of sailed through it? And what treatments are available? And we can cast the net wide, but then I also think we have to be practical. Are these treatments available? Are they here? Are they somewhere else? And if they're somewhere else, is that something the patient is willing to do? Do they want to travel and travel repetitively for potentially something somewhere else? And last but not least, but most important, what are the person's priorities and goals? What are we hoping to accomplish with all of this? Because I think that needs to be a part of the discussion across the board. I then think about the melanoma. How much? Do they have big tumors, little tumors? Where are they in the body? Are they involving more delicate parts of the body like the brain or the liver, or things like the skin and other stuff? Are they causing symptoms, or the tumors just there on scans and we wouldn't know they were there had we not done that? We get concerned if things are causing problems, like pushing on important parts of the body. How much melanoma is worsening? Again, this speaks to, do we have just kind of one tumor escaping the control, or do we have lots of tumors escaping? Did the melanoma grow through the PD-1? This goes back to that resistance. Do we think they got any benefit out of it, or do we think that it didn't do anything for their tumor? And how fast is the melanoma changing? This all factors into kind of the next step too of what we would pick, and do we think somebody is going to be well enough to get to the time frame they need to get to the next treatment? And last but not least, are there anything targetable? BRAF mutations are very important. There's less common mutations that we certainly test for, and we need to make sure not just for immunotherapy options, but what other options are there? Molecularly targeted pathways, this is an abbreviated slide, not meant to be exhaustive, but these are kind of the top genetic mutations we tend to think about. And I want to emphasize these are the genes in your cancer cells, not the genes that you're passing on through the family. BRAF is the most common one we think about, and this is more predominant in cutaneous melanomas in about 40 to 50%. NRAS is in about 10 to 15%, typically more cutaneous, but we can see it across the board. KIT mutations are actually pretty rare in all melanomas, but more frequent in mucosal or acral. And then we have G protein. This is that G protein complex up here, GNAQ and GNA11, which is pretty much representative of most uveal melanomas. And this is a selection of some of the targeted therapies available, but not an exhaustive list. So then we think about what treatment options are currently available. And this is meant to focus on things that are at this point FDA approved. In the immunotherapy world, we have, as you are probably well aware, IPI with Nivo, relatlimab with Nivo. We have single agent PD-1 inhibitors, nivolumab and pembrolizumab. Ipilimumab is still approved as a single agent. We have high-dose interleukin-2, which is an older cytokine therapy, so an immunotherapy, but not a checkpoint inhibitor. T-VEC or telimagene laherpivec, which is an oncolytic virus that's injected into tumors on the surface. Tebentafusp or Kimtrac, which is approved for uveal melanomas. And then you're going to see a theme of a bolded 2 words throughout my entire talk of clinical trial. Cell therapy. Currently, the FDA-approved cell therapy is lifileucel. Clinical trials, important. Targeted therapies. We have BRAF targeted agents, 3 different doublets, clinical trial. KIT, imatinib, dasatinib, there's other agents as well, clinical trial. NRAS, we can kind of target with a MEK inhibitor by itself, but I put clinical trial above that because we want to do better than what we can do right now. And then we have combination therapy, which at this point involves both an immunotherapy, a PD-L1 inhibitor, atezolizumab, with vemurafenib and cobimetinib, and a clinical trial. Treatment options. I don't like to throw out my tools. I think all of my team has heard me say that over and over again. So chemotherapy or cytotoxic chemo is not high on my list, but for some people, this is an option. So temozolomide, dacarbazine, carbotaxol, others, and then clinical trial. Local therapies, so things that are going after one part of the body for the most part, as opposed to what we've been talking about, systemic therapies that go throughout the body. Surgery, radiation, the oncolytic virus that we just talked about, TVEC. And then there's other local therapies that you can hear about depending on parts of the body, as well as expertise throughout the country, such as histotripsy, ablation, and clinical trials. Many trials, again, trying to combine some of these with agents that we already have or newer agents. So, what are the benefits of the treatments we're talking about for each individual patient? What are the potential risks or side effects, and are they different for this particular individual than the average population? How quickly do we need to start the next treatment? Is this somebody who could wait to figure things out, or is something moving very quickly and we need to get them started sooner rather than later? How quickly is the treatment we give going to start working in the patient? This matters if the tumors are causing problems. So traditionally, immunotherapy medicines sometimes take longer to take effect. There are some exceptions to that, whereas some of the targeted therapies, if you have the right target, might work faster, but sometimes they don't have that same durability of benefit of immunotherapy. Does the person have active side effects that are going to factor into what we can actually choose for them to go on to next? Do we need to pick something first and then maybe have a backup plan later down the road? And are treatments available, again, at the current location? Are there clinical trials? So the first option, can you adapt what you're already using? If you think somebody's getting a majority of benefit of a PD-1 inhibitor, I'm going to argue, and we have one tumor progressing, maybe we could treat that one tumor. Could we cut it out? Could we irradiate it? Could we put some TVEC into it? But could we actually use the control we have for the majority and try and adapt for the one that's not working? Or we think there's too much that's not working and we need to switch. You think about things like if you received only a single agent or a relatlimab-nivolumab combination, maybe you need to think about ipi-nivo. Again, this is a bigger conversation with your doctor, understanding what's going on with you medically. Is this reasonable? What doses would we consider? Again, clinical trial. If you've already received ipi-nivo, we think about, is TIL an appropriate therapy to think about? A clinical trial if there's no BRAF mutation. There is a BRAF mutation. Again, BRAF inhibitors may be appropriate. There may be a trial involving BRAF inhibitors or something else. Cell therapy, and we have an expert in cell therapy coming next for our next talk, Dr. Amaria. So I'm going to give just a brief overview. TIL, or tumor-infiltrating lymphocyte, and ACT, or adoptive cell therapy, these are kind of a continuum of a similar concept, and it can get a little confusing. Lifileucel is the only FDA-approved cell therapy, a TIL therapy, currently for melanoma since 2024. And currently, the indications are for somebody who has already been treated with a PD-1, and that could be either as a single medicine or in combination. And if they have a BRAF inhibitor, that they have been exposed or treated with BRAF MEK inhibitors. So this is at this point not FDA approved to give as the first treatment to someone. Clinical trials are investigating, should we adjust some of that? Should we move it sooner? Can we do it in a different way? Currently, TIL therapy involves a surgery to take out a tumor that has T cells in there, and we want to isolate those T cells and expand them, create the product, and then give those cells back, typically in the hospital, in the context of chemotherapy to try and get rid of the bad T cells, what we want to replace with the ones we're giving, and then interleukin-2, currently administered as high dose, which has to be done in the hospital. General concepts, not everybody is maybe going to be well enough to get TIL therapy. This is for people who are generally reasonably healthy, their organs are working. That's kind of the concept. So good kidneys, good liver, good blood counts. We cannot have active brain involvement from the melanoma. So the brain needs to be controlled or no brain involvement. And at this time, we need a tumor big enough to cut out to actually generate enough of those cells that we can safely surgically remove. This involves, like we said, surgery, chemo, high-dose interleukin-2 in the hospital for about 3 to 4 weeks. And this takes time to work. So if we have somebody's cancer that's growing rapidly, that makes me a little nervous that maybe the cancer might be moving faster than we can get the treatment into them. With some additional options of switching, you could switch to a targeted therapy or an other therapy. If somebody has already received immunotherapy, didn't respond, consider BRAF inhibitor therapy if they have a mutation. If other mutations, consider those. Chemotherapy is on the table, and these are kind of some scenarios I could imagine. They can't participate in a trial or TIL. They've already received or can't receive BRAF/MEK. They have serious ongoing immunotherapy-related side effects where more immunotherapy is not safe, or they're not able to receive it for other reasons. Research and clinical trials are ongoing. What we already alluded to a little bit is there's lots of studies ongoing, and Dr. Amaria is going to talk about some of these with the goal of trying to increase the benefit of TIL, lessen the side effects, adapting the regimen, adapting the way we collect cells or prepare the cells, and maybe even moving it earlier into the course of melanoma treatment, where again, this is at this point only for advanced unresectable after exposure to PD-1 and possibly a BRAF inhibitor if BRAF mutated. These are some 2 agents that are kind of promising and in trials that I believe she will be talking about. The other concept for research trials is, can we make tumors more sensitive to PD-1 therapy? That's not only from the beginning, but maybe even after somebody has already had response. And so that can be in a variety of ways, including novel combinations such as ipi-nivo-relatlimab. This is a schematic, a lot of information, but these are other checkpoint inhibitors when we think about it. So you can see something here called TIGIT. There's others. This is LAG3, CTLA4, GITR. A lot of these have either been in studies, ongoing in studies, and so more checkpoint inhibitors may have a role. There is another oncolytic virus that many people have heard about called RP1. The application has been resubmitted, I believe, this week to the FDA. And so again, this is the concept of a modified virus, in this case, a herpes virus, that has also another molecule called GM-CSF that it can elute. This is an immune modulating agent injected into tumors, and then with the goal of having cell destruction by a couple different mechanisms. This is being investigated in combination with nivolumab, a PD-1 inhibitor. And this is involved in injections not just to superficial tumors, but also deeper tumors in different parts of the body. Antibody drug conjugates are another area of fertile research, not just in melanoma, but across the board. And this is a molecule that has an antibody that's going to try and bring a chemotherapy or targeted therapy agent to the cancer cells. So you're kind of trying to deliver the treatment that you want to give right to the area where the cancer cells are to hopefully have more cell destruction. So you got to figure out the target and you got to figure out the cytotoxic agent. And then we have other molecular targets. So pan-RAF inhibitors is a little bit of a different concept because the BRAF inhibitors we have are very specific for certain mutations. PMRT5 is another inhibitor that is kind of working its way through. And again, this is not meant to be exhaustive, but to give you some ideas. And then a lot of work in vaccines. V940 is a vaccine from Merck that's under investigation, an mRNA vaccine. IDO1 is another vaccine that's been under investigation from another small biotech company with some recent results presented in Europe. And this is another schematic, just kind of saying, okay, well, this is where we've got lots of antibodies that we're already familiar with. We're looking at mRNA vaccines. The gut microbiome is a whole nother topic for us to consider, but can we make immunotherapy work better and have less side effects? Nanomedicine kind of speaks a little bit to that antibody drug conjugate and then the oncolytic viruses we discussed. So I like to say that treating melanoma is a chess match. You got to kind of think about what your options are, and there's usually going to be a couple options for every patient. But I tend to think about what I want to do from the beginning. I don't want to just think of the next step, but I've got to kind of plot and plan if my first choice doesn't work. Treatment recommendations are highly dependent on the individual, their health, their melanoma status, their goals and priorities, as well as their response tolerance of prior treatments. Ongoing research is been going on and will continue to go on, looking at not only using the treatments we have in new and different ways and combining them with other things, but also varying those treatments and using new ones in combination. Please consider participation in clinical trials. This is always voluntary, but there are options for many people. Thank you.
Yeah.
I think I have the wrong one.
Which power?
It's going to be through the Zoom.
Oh, through Zoom.
Mhm.
Okay, so they'll have to pull it up
Okay,
and then,
should we do them first and stuff? That,
so that's fine right
okay,
here.
I think they're doing
So, but then what we'll do. So I have to come back up here so I can show this. It's gonna be like that.
Thank you.
And-
It's my pleasure to introduce Dr. Rhoda Amaria. She is an accomplished hematologist oncologist who trained at the University of Colorado and joined the University of Texas MD Anderson in 2013 with the Melanoma Medical Oncology Department. She cares for patients with advanced melanoma and is highly involved in research. She is the director of clinical research for the Melanoma Medical Oncology Group and leads the MD Anderson Adoptive Cell Therapy and Tumor Infiltrating Lymphocyte Program, as well as co-directs the Biospecimen Collection Program in the Melanoma Clinic. Her research interests include evaluating biomarkers of response and resistance to therapies, the tumor microenvironment, neoadjuvant therapies, and adoptive cell therapy. Dr. Amaria, thank you so much for joining us.
Thank you so much, Dr. Fetcher. I hope you can hear me okay. I appreciate the opportunity to present over Zoom today. I am assuming everything is good, so I'm going to just march on through. Here are my disclosures. Okay, so what we're going to do today is talk about a couple of areas of cell therapy in melanoma. We'll focus mostly on tumor infiltrating lymphocytes since we do have a standard of care treatment. Talk a little bit about an experimental TIL, and then we'll wrap up by talking about a T-cell receptor therapy currently being used in clinical trials. So let's start with TIL. So the idea for TIL therapy actually came from three seminal experiments back in the 1970s to 1980s. So first of all, there was identification that infusion of splenocytes, which is just a way of saying T cells, can actually control tumor growth in mouse models in sort of a dose-dependent way. So the more T cells you give, the more tumor control you could get. There was identification that these T cells worked better in immunocompromised hosts. So basically, if you irradiated these mice, the T cells actually worked better in controlling the cancer. And the final important observation is that high-dose IL-2 could actually be used as a cancer-fighting tool simply because it can be used to empower and activate these T cells to make them more active and to better able to kill cancer. So those were the three most important things that went into the development of the initial TIL trial, which included 20 metastatic melanoma patients. This was published in the New England Journal in 1988. So the idea here was that patients underwent 7 days of lymphodepleting chemotherapy, including cyclophosphamide and fludarabine, had a single TIL infusion with the characteristics shown on the slide, and then high-dose IL-2 to promote proliferation proliferation and activation of these T cells. And amazingly, this actually was beneficial. So 60% of patients actually benefited. And this was hugely important because back in those days, really wasn't much that could be done to manage patients with metastatic melanoma. Most of these people were dying within months of diagnosis. So the fact that 60% of these patients benefited and some of them durably was really quite eye-opening. And although the NCI really piloted and pioneered all of the initial science behind this, different institutions across the world were trying to create TIL programs, which is hard. This requires a lot of time and money. You have to have a GMP certified facility to grow these T cells. And so honestly, the development of TIL was largely just at the NCI, with other small academic centers sort of trying to contribute as well. So there has been a big center at MD Anderson for many years, but internationally, groups in Denmark, groups in Israel were also trying to do their best to make their own TIL program to sort of replicate the NCI data, but then move beyond it with some novel research technologies. So with that background, Iovance came into development now within the last 10 years. And so the idea was to take the learnings from the NCI, all of the methodologies for manufacturing, and standardize it, put it all in one central facility that could serve as just a manufacturer for any patient basically anywhere across the US. So the idea is that the patient underwent sort of a screening process, made sure they were healthy enough, had surgery to procure the tumor locally. That tumor gets packaged up sterilely. It meets a courier. That courier jumps on a plane and delivers the tumor to the manufacturing center. The manufacturing occurs, and then when the cells are ready, they get flown back to the treatment center. The patient undergoes the 7 days of non-myeloablative lymphodepleting chemotherapy, the single TIL infusion, and then up to 6 doses of high-dose IL-2. In this clinical trial that led to the accelerated approval of lifileucel, 153 patients were treated. Most of them had cutaneous melanoma. There was a small group of mucosal patients and acral patients included. Importantly, all of these patients had to be PD-1 refractory in order to qualify, and patients with BRAF mutations needed to have some degree of exposure, but not necessarily resistance to BRAF and MEK. Most of these patients were relatively well, I would say. There were people that had elevated LDHs, which, the more elevated the LDH, the more we worry about aggressive disease phenotype. So most of these patients had, only a minority of patients, I guess I would say, had elevated LDH. But again, most of these people had real disease, were heavily pretreated. So in what we see here is that there are 2 different cohorts of patients treated. Cohort 2 was, I think, the weller population of patients. So these were people, the overall response rate was 34%. They then went and enrolled another 87 patients in cohort 4. This was a more real world population, bigger disease burden, more elevated LDH, and the ORR fell to 28%. So overall, with the pooled cohorts, it's about 31.4%. That are benefiting. We did see initial data suggesting improvement, so OS of about overall survival about 14 months, PFS about 4.1 months. And when we look at subgroup analyses, unsurprisingly, people with lower disease burden, normal LDH, did better in terms of having more durable benefit from this therapy. Importantly, this is a toxic regimen, but I would say it's sort of predictably toxic. So you're going to have toxicity related to the lymphodepleting chemotherapy, which could lead to neutropenia, neutropenic fever, requirement for blood or platelet transfusions. And then you can have toxicities from the high-dose IL-2, which includes hypotension, capillary leak, could cause trouble with cardiac toxicity and lung toxicity. But what you'll notice is that the side effects of the therapy are really limited to the duration in the hospital. So mostly patients are hospitalized for 2 to 3 weeks for this treatment, and they are hospitalized for the duration of their treatment and their toxicities. But it should be noted that this is a very toxic regimen. With everything that the patients undergo, there is a chance for morbidity and mortality at every time. There was a treatment-related mortality rate of 7.5%, and that was in a clinical trial setting where patients were heavily pre-screened and picked. So do have to be aware that this is a very toxic regimen. What we do see, though, is that with updated follow-up, we can see that responses can be ongoing and deepening over time. We also see about, this is the overall survival curve, just updated at our most recent ASCO meeting, suggesting that, about 20% of patients can have good long-term durable benefit with the tail of the curve that we look for in immunotherapy. So, Iovance is up and running. There's over 50 authorized treatment centers across the U.S. So far they can scale up to about 5,000 TIL products being generated a year. This is all really important. But as I've said, this is about a 30% response rate. There's a 7.5% treatment-related mortality. It would be wonderful to be able to understand which of our patients would really benefit for the best. So is there a scientific thing we can ask that would be predictive? And so we used to have this dogma that the higher the cell dose, the more patients benefited. We're not really seeing that. This is sort of a scatter plot showing that there's really no correlation. Patients with good response could have low cell dose or high cell dose. We looked at, is there specific features of the infusion product? Are higher CD8 cells better than higher CD4 cells in the infusion product? Again, a little unclear that we're seeing a clear predictor of who or what features of the cells are going to be most predictive of response. Looked at difference in gene mutations. Are BRAF patients going to do better than NRAS or c-KIT? Bottom line here, nothing correlates. And the final thing that was looked at was gene expression profiling, looking at inflamed or non-inflamed tumors, looking at tumor mutation burden. And again, really no good predictor of who benefits or not, which is very frustrating, I would say, because of the toxicities associated with this regimen. So my assessment is that this is, a huge milestone that we now have a standard of care TIL therapy, and there is proven efficacy in patients with ICI refractory melanoma. However, I would say that the 30% response rate, represents a highly selected patient population, and real-world implementation of this regimen has been challenging. And I'll speak for our experience at MD Anderson. We're not getting 30% of patients benefiting, and we are seeing a lot of toxicities, a lot of times because of the desperation of this patient pool. So again, these patients unfortunately can be a little bit more roughed up, a little bit more symptomatic when they come off their checkpoint inhibitors and go on to this treatment. And so again, because this is a toxic regimen, it really can lead to a lot of morbidity and mortality. So if I had my ability to make TIL better, I think there were 3 things that I would really work on. Number 1, I would lower the amount of lymphodepleting chemo, because that 7 days really does cause a lot of toxicity, neutropenic fever issues, septic shocks, need for transfusions. I think the cell manufacturing time would ideally be 28 days from time of harvest to treatment. The current standard of care, the manufacturing should only take 22 days, but there's a lot of extra work tacked on for release criteria. And so we're often not getting cells sent back to us for 5 weeks, which is, a lot longer than I'd like. And then reducing reliance on exogenous cytokines, I think, is important. High-dose IL-2 can be toxic. It can cause cardiac and pulmonary toxicities, renal toxicities. It can be a bit unpredictable. And so not having to use IL-2, I think, would be helpful. And then again, as I've just discussed, it really would be helpful to have biomarkers to understand which patients would best benefit from this therapy and which would be, better able to sort of sustain the rigors of this regimen. So with that background, I'll talk a little bit about OBX-115. So this is an engineered TIL where you take a tumor, either through surgery or multiple core needle biopsies collected by interventional radiology. And then basically these cells are engineered with a fusion protein coupling membrane-bound IL-15 with a drug-responsive domain derived from carbonic anhydrase. So the idea, I know that sounds complicated, but it's actually pretty easy. If you give the ligand for carbonic anhydrase, which is acetazolamide, an old-fashioned diuretic, you basically turn the cell on. When the cell is turned on, membrane-bound IL-15 is expressed, and therefore you make your own cytokine. You can basically control the expression of this IL-15, whether you give acetazolamide or if the patient has toxicities, you can simply withdraw the acetazolamide, the cell turns off. So in this way, you've created a cell that is inducible and regulatable in terms of their cytokine expression, and you don't have to give exogenous high-dose IL-2. So I ran this study at MD Anderson starting back in 2023. This was for patients with metastatic melanoma refractory to ICI therapy. As I mentioned, we could obtain tumor either through core needle biopsy or surgery. Patients initially got the standard 7 days of high-dose lymphodepletion, single TIL infusion, and then we were planning to give acetazolamide basically every day. This was a first in human study, so endpoints were really safety and tolerability. We treated our first patient. This was around Christmas of 2023, young woman. And she had amazing cell manufacturing. She actually manufactured 150 billion TIL, which is the max we give patients. And as you can see, we treated her and she had massive proliferation. This is her absolute lymphocyte count. So she went to 30,000 lymphocytes, which is basically massive proliferation of her OBX TIL in a very short period of time. And that led to a lot of unusual side effects, I guess I would say. Terrible rash, mucositis, hepatitis, thrombocytopenia. Basically, she had all of these toxicities just due to massive proliferation of these T cells. These T cells invaded everything and basically led to toxicities. Amazingly, this patient went into a complete response, remains in a complete response now almost 2 years out from her treatment. But because we had this sort of massive proliferation, we learned quickly these engineered T cells are very potent and ended up changing the protocol, implemented dose levels of the TIL, as well as reduced the dosing of acetazolamide and the duration of the acetazolamide. We went on to treat multiple subsequent patients from that trial, had a really good experience, and that led to this currently enrolling multi-center study, again with dose levels of the OBX TIL. And in melanoma have decided on a cap of up to 100 billion TIL with 500 milligrams of acetazolamide at what we call the split dosing. This is an ongoing study. Some updates had been presented at ASCO this past year, just with 11 patients. Again, all of them are PD-1 refractory patients. Essentially, most of them had PD-1 and CTLA-4 and were primarily resistant. These patients mostly had 3 lines of prior therapy. And again, we can see with this sort of split dosing of acetazolamide, we are having a manageable side effect profile. You can get not really CRS, but you can certainly get what I call cell therapy induced fevers. but those are relatively easy to treat with a single dose of steroid, and patients can actually get through this treatment very well. I'll also say that in this trial, we've implemented a lower dose lymphodepletion. So instead of 7 days of lymphodepletion, it's 4 to 5 days of lymphodepletion, which you can actually get as an outpatient. And again, tumor response is actually pretty impressive. So at the dose level 3 with up to 100 billion TIL, we're getting our best responses. 66% of patients are responding, and we are seeing relatively durable responses, although this is presented pretty early before we have a lot of mature response data. So in my mind, again, we know that this regimen can be highly effective in PD-1 refractory patients. This TIL is, I think, innovative. It allows for lowering of the lymphodepletion, reduces the reliance on exogenous TIL cytokines. We're not using any high-dose IL-2, and we're able to actually grow TIL from core needle biopsies. But this is still a bit of an issue. The manufacturing is still way too long. It's taking 6 weeks due to the transduction of the T cells. And again, we actually do have some interesting biomarker data of response, but I didn't add it here due to time. And then, we are running out of time, but I wanted to just focus on a really novel cell therapy called T cell receptor therapy. And this is IMA203. And so basically what this is IMA203 is a TCR T cell that is specifically designed to target PRAME, which is expressed in the context of a patient's HLA molecule. And specifically, this is engineered to recognize HLA-A0201, which is found in about 30 to 40% of Caucasians. PRAME is highly expressed in various melanomas, including cutaneous melanoma and uveal melanoma, but is also seen in other solid tumors. And so in this initial phase 1 trial, patients with metastatic melanoma refractory to checkpoint inhibitors with HLA-A0201 were eligible to enroll. They underwent leukapheresis, so no TIL, no resection of tumor, leukapheresis to collect the T cells, 2-week manufacturing to make the IMA203 with 95% success rate. Patients receive a low-dose lymphodepletion regimen of fludarabine and cyclophosphamide. The cyclophosphamide dosing is very low compared to the doses given with lifileucel. They get a single IMA infusion and then subcutaneous IL-2 over the next 10 days, which is, clearly better tolerated than high-dose IL-2. 74 patients were initially included in this phase 1 study, including 33 melanoma patients sort of treated at the in the phase 1 dose expansion. This was a dose escalation, and they selected a dose of 1 to 10 billion TCR T cells as the recommended phase 2 dose. If again, this study included both cutaneous and uveal melanoma as well as other solid tumors. If we look at the melanoma, 33 melanoma patients, we saw again heavily pretreated patient population with multiple lines of prior therapies and a big tumor burden. And again, most of these patients are getting medians about 4 billion of these TCR TIL. The side effect profile here with TCR, sorry, not TCR TIL, TCR. The side effect profile with this TCR is different. You are having toxicities related to the lymphodepletion, although not that bad because, again, the regimen is a lot lower. But you are seeing true CRS. So you are seeing high-grade fevers. You can see associated hypotension, tachycardia. But most of these toxicities are grade 1, grade 2, and easy to manage with administration of tocilizumab. And in some patients that don't respond to tocilizumab, you can give steroids. But in general, these CRS events are occurring very early on while patients are hospitalized. You're not really having this long term. And in general, this is a relatively well-tolerated regimen, although, again, requires inpatient treatment. And importantly, overall response is very good. So best overall response in the 33 melanoma patients included in this clinical trial was 56%. And again, PFS is about 14 months. OS, again, 14 months or so I'm sorry, PFS about 6 months, OS about 15 months in this small group of melanoma patients. So based on this data, there is now an ongoing, hopefully registrational trial, randomized phase 3 trial, using this IMA 203 versus standard of care treatments. Based on this really good data that we saw in both uveal and cutaneous melanoma. Again, unlike TIL, you definitely do see true CRS, but it does tend to be, relatively well tolerated with tocilizumab. This is obviously a selected patient population. Only the HLA-A*02:01 patients are eligible. And in the current registrational trial, it's only limited to cutaneous melanoma patients, and there are some LDA restrictions. They don't want to enroll patients with really over 3 times upper limit LDH. Identification, again, of biomarkers of response is ongoing, but I think there are several interesting aspects of this regimen that make it very attractive. So I'll just summarize and say cell therapy is really exciting. I think it's hopefully I've shown to you that it can be a salvage regimen in patients with ICI refractory melanoma and really a good option for patients with prior ICI toxicity. But this is, toxic regimen. You really do have to have people that are fit enough for this. And so, absolutely toxicity and efficacy concerns exist with the current standard of care. And fortunately, there's a lot of work ongoing to address some of the shortcomings, including lowering the lymphodepletion, hopefully shortening the manufacturing time, reducing the reliance on the high-dose IL-2, and again, critically important to understand biomarkers of response and resistance. So I will end there. Thank you so much for your attention today.
Dr. Amaria, I know you have to round in the hospital. Since you won't be able to join us for the Q&A, could I ask you just a few questions while we have you?
Sure thing. Yeah, absolutely.
Okay. Our first question is, what would you consider an elevated LDH in preparation for TIL therapy?
Yeah, so I mean, with great question. Yeah, I think LDH that's over 2 to 3 times upper limit of normal, we worry about those patients. And again, because the manufacturing of standard of care TIL is taking 5 weeks, and in our center, it's taking, 4 weeks even before that to get insurance clearance and schedule an OR, it's a long runway. So if you have a person you're considering and their LDH is already elevated, I think it's going to be a bit of a challenge. And as I said, the Ematics people are being very selective. So they will not take people with over 3 times upper limit of normal LDH. So I think that's kind of the cutoff that we're seeing.
Thank you so much. The next question is, why are patients with brain metastases excluded from TIL therapy? Is it not effective in the brain?
So I didn't touch on the fact that there is actually a study that has been done with TIL in patients with active brain metastases, a small pilot study out of Memorial Sloan Kettering. So to answer the question, no, TIL can be effective in the brain. And in fact, we've known that for a long period of time. The reason why we don't like to do it is because of the lymphodepletion. The lymphodepletion can cause your platelets to go into single digits. And if you have brain mets that bleed at baseline, causing severe thrombocytopenia is not going to help that process. And so now that TIL is again standard of care, and we are sort of pushing the boundaries, we are actually at MD Anderson treating patients with active brain mets, but with a very abbreviated lower dose lymphodepletion regimen, and with a lot of caveats here. We are really telling patients the risk. If we cause severe bleeding in the brain, this can be life-ending. And so that is the main reason why. There can be some issues with high-dose IL-2 and cerebral edema. I don't really think that's the main issue. It's really the bleeding, the lymphodepletion risk that I worry the most about.
Thank you so much. And last question, acral melanoma was not listed for T-cell therapy. Does that mean it's not effective for acral?
Acral, yeah, absolutely. You can use TIL and cell therapy in acral melanoma. It's mostly not excluded. There were a group of acral patients in the Iovance trials. It's being allowed on the Obsidian trials. Currently, Immatics is very restrictive. It's really only cutaneous melanoma or uveal melanoma in a separate trial. But in general, acral should respond. I will just say that again, I really applaud Iovance for including mucosal patients in their registrational trial. It was a small group, but honestly, now that it's standard of care, we're actually treating a lot of mucosal patients. If I look at our demographics, 20% of the people we are giving standard of care TIL to are mucosal. We have a ton, and unfortunately, mucosal patients are excluded from clinical trials. So a lot of them will get standard of care TIL. And we're seeing benefit. So, you know, again, a big plug to not exclude these patients. I feel strongly that these poor patients get excluded. But fortunately, you know, there is a standard of care Iovance that does seem to be an option for both acral and mucosal patients.
Thank you so much, Dr. Amario. We appreciate you joining us, and thank you for a wonderful talk.
Thank you so much. Again, thank you.
All right. I'm going to introduce my colleague, Dr. Sarah Jens. She is a medical oncologist here and clinical associate professor in the Department of Medicine and has a joint appointment at the Ann Arbor Veterans Affairs Hospital. She also serves as associate residency program director in internal medicine. She joined the faculty in 2018 after training here, as well as at Northwestern for her residency. And she has a clinical focus in melanoma, as well as genitourinary tumors and Merkel cell carcinoma. She's involved in clinical research, and her passion is medical education. Thank you for joining us.
Thank you, Leslie, and thank you all for being here. Those of you in person, those of you online. So yeah, we're going to move a little bit earlier in the disease process in melanoma. You guys heard about, you know, treatments that are given in the metastatic setting. We're going to move much earlier than that. And so we're going to be talking about stage 3 melanoma, particularly node-positive melanoma. So obviously we hope none of our patients ever have a recurrence of their melanoma, but we want our patients to be prepared to know what to do if that happens. So we'll go over, you know, who to call and maybe some diet changes to consider if in the setting of needing treatment for melanoma. So to kind of illustrate this, we'll talk about Miss M. So Miss M was a 45-year-old. She had a melanoma on her abdomen removed in 2022. Was doing well for a year, and then in 2023 felt a lump in her groin. So she's worried that it's melanoma coming back, and so she calls the surgeon who took the melanoma off, and she goes to see him, and he says, you know, I can take that out for you next week. Yep.
Need to share the screen with the online folks.
Sure.
My apologies.
So for the online folks, all you're seeing right now is a picture of a surgeon telling I can take that out for you next week. Which, you know, Miss M is like, great, it's so hard to get an appointment. We sure take that out. But if I were advising her, I would actually tell her to not have that surgery. And we'll go through why. And the reason why is that Miss M should really see a medical oncologist, someone like myself, Dr. Fesher, my other colleagues who are going to speak first before surgery with the goal of getting immunotherapy before having the surgery. So we'll talk a little bit about why. So Dr. Fesher had gone over the rationale, how immunotherapy works, but just to review again, you know, our T cells, our immune cells can go and fight melanoma, but when they get there, they get blocked. They get blocked by the PD-1, PD-L1 interface. And so what the drugs that maybe you guys have heard of before called Keytruda, Opdivo do, they block that the receptor on the melanoma so that your immune cell can really fight the melanoma. So prior to 2023, this was the workflow. The workflow was if you have a melanoma recur in a lymph node, then you should get it taken out and then see a medical oncologist to consider what we call adjuvant or after surgery type of immunotherapy. But since 2023, this is the recommended workflow for melanoma that has traveled to a lymph node. So now we give immunotherapy first, the patient goes to surgery, and then they get more immunotherapy after. And this is the reason why. This is what kind of the hypothesis was that led to some clinical trials that I'll show next. But when you do surgery first, you take out the melanoma, you take out the majority of it, hopefully all of it. But in some situations, a few cells are left behind. And then the goal of the immunotherapy is to kind of clean up those cells. And when the immunotherapy comes in, it's able to generate a few activated T cells, and those are supposed to try and take care of the rest of the melanoma cells. But if we give immunotherapy first, when there's more melanoma, what we call antigens, or just pieces of the tumor present, you're able to activate many more T cells. So after you take it out, you still have all those activated T cells, which are able to better attack the residual melanoma. So that's kind of what we presumed was happening, and that bore true in clinical trials. So these are the two clinical trials that changed practice in 2023 and then subsequently 2024. So just orient you, the blue lines are the patients who got immunotherapy before surgery. The axis here is alive and no melanoma. So in both of these trials, they were called SWOG 1801 and the Nadina trial. The patients who got immunotherapy before surgery, again, these blue lines, did significantly better than patients who just got immunotherapy after surgery. So this has become our standard for patients who have melanoma that's recurred just in a lymph node. So as a summary of this section, just things to remember is if a melanoma were to show itself again, and especially particularly in a lymph node, we would recommend biopsy first, not taking it out completely, seeing medical oncology. And the reason is because patients do better when immunotherapy is given before surgery rather than after. So moving on to the second part, I mentioned a little bit about kind of changes in diet. So, it is very common that when patients see me for the first time, they ask, well, is there anything I can eat or not eat that is going to help? And I can understand the reason for the question, right? Cancer completely takes away all control over your life. And one thing that you do have control over is what you eat. And so I think patients look to food as a way to gain back some of that control. So prior to this year, really, if patients asked me this question, this would have been my response. I would have just said kind of just everything in moderation, no food that's really going to decrease or increase the chance of cancer growth. But now patients ask me this question, this is what I say. I talk about fiber. And this changed for me after hearing a talk by these really awesome women medical oncologists, Dr. McQuaid and Dr. Zitvogel. So they gave a talk at our big cancer meeting that happens once a year about the microbiome and the role that fiber has on that. So we'll go into a little bit of the data that they shared. So the first started actually years before with just looking at patients with metastatic melanoma and kind of a survey study of what are you eating, and particularly asking about how much fiber patients were eating. And the patients who had sufficient, what they deemed to be sufficient fiber, actually lived longer than the patients who didn't have as much fiber in their diet. So then they said, well, there's a lot of things that go into survey reporting studies, like maybe these people were just healthier in general. So they said, let's try and see if we can replicate it in the lab. So they took mice, they gave those mice melanoma, and then they gave them anti-PD-1, so equivalent of mouse Opdivo. And then they fed half the mice a high fiber diet and half the mice a low fiber diet. And this is how big the tumor got. And you can see the mice who had a high fiber diet, that tumor didn't grow, but with the low fiber diet, it grew even though they were getting immunotherapy. They then kind of went back to say, why could this be happening? So this is the proposed mechanism, is that fiber leads to growth of good bacteria in the gut. And then those good bacteria ferment fiber into short chain fatty acids. And these short chain fatty acids may enhance the T cell fighting ability when in the context of immunotherapy. Again, mice studies are good, but if everything that worked in mice worked in people, we may have cured cancer by now. So we really got to prove it in people. So this is the first study that they did kind of trying to prove that. So it was 45 patients with melanoma. Half the patients got a high fiber diet, 50 grams, and half got a more regular 20-gram diet. The high fiber diet, so they actually provided the food in the study to make sure this was very well controlled. So this was what they ate, I think actually every day. Maybe they changed it up, but really not bad, right? A whole grain English muffin, turkey sausage, side salad, chicken burrito bowl. So not eating cardboard. So this is what patients in the high fiber group ate. They did not, I mentioned there were 45 patients in the study. Not all of the patients had measurable melanoma. So some patients were in that neoadjuvant or adjuvant stage, or really an adjuvant stage where they couldn't measure the change in size on tumors on a CT scan. But of the patients who could have their tumors measured, they said they looked at how much they grew or shrank. And so these are graphs we pretty commonly use in our papers where above this line here is tumor growth and below here is tumor shrinkage. And, thankfully a lot of patients had shrinkage, but wow, a lot more in the high fiber group had shrinkage than in the control group. And really none of the patients in the high fiber group had growth above 20%, which is kind of our threshold to say that's kind of a clinically significant amount of growth. So again, small study, would love to see 2,000 patients rather than 20 patients. But I think there's pretty a low downside to thinking about incorporating more fiber in your diet. So now I standardly kind of talk about this with patients, give them this link. Sloan Kettering has put together just a nice patient-facing site that lists a lot of foods that have high fiber in them. So quick thing to just kind of scroll through. So I'll really end there. Like I said, it's I think would love more numbers and data, but I think pretty low downside. And so we'll end with some nice pictures of some high fiber stuff you can think about adding in for your next meal. That's all I have. Thank you.
Thank you, Dr. Jens. So our next speaker will be Dr. Watayas. Victoria Watayas is a medical oncologist and clinical assistant professor. I gave you a promotion in the Department of Medicine here at University of Michigan. She joined the faculty in 2024 and completed her training here. She has a clinical focus in both soft tissue and bone sarcomas, as well as melanoma, and her research interests include mental health outcomes, including body image distress and anxiety in adolescents and young adults with cancer throughout the cancer course.
Thank you. Good morning, everybody. Thank you for having me. So like Dr. Fetcher said, we'll take it in a little bit of a different direction and focus on some of the ancillary things that our patients deal with, and specifically the psychosocial distress. My research interest in terms of population is adolescents and young adults, but I think a lot of the things I'm going to talk about today really are appropriate for all ages. There we go. So just as a brief outline, I just want to take a few slides to talk about adolescent and young adult cancer kind of as a general group and the psychosocial distress challenges that a lot of those patients face in particular. And all of this will be certainly with the melanoma bent to it. And then two specific areas that I am interested in, infertility and fertility preservation. And as Dr. Fetcher mentioned, body image distress and anxiety during the cancer course and in the survivorship setting as well. So we often think of the adolescent and young adults cancer group as based on age. And the official definition is our patients that are aged 15 to 39. So a wide spectrum. But in thinking a little bit beyond just the age spectrum of adolescents and young adults, I think it's important to consider the multiple developmental stages that group encompasses and all the diversity even within those developmental groups. This figure comes from an article of the Journal of Adolescent and Young Adult Medicine in 2016. And I think it's nice because it really highlights that the adolescent and young adult experience in life in general outside of a cancer diagnosis has a lot of challenges as people are facing changing timelines, developmental tasks, meeting certain milestones. So just something to keep in mind that the adolescent and young adult group is more than just kind of their age. So the challenges that our patients face extend into the survivorship setting as well. Up to 1/3 of AYA cancer survivors, so patients that have completed their treatment, experience what would be considered moderate to severe symptoms of anxiety and depression. And almost 50% of this population suffers from significant post-traumatic stress disorder symptoms within 2 years of their diagnosis. It can be challenging to measure psychosocial and psychological outcomes, especially for this age group. So thinking of a framework can be helpful. And that's where I bring in this framework. This is from a very recent publication last year, looking specifically at psychological outcomes in our AYA cancer survivors. The inner circle focuses on the functioning groups and things that can be our focus when we think about what important outcomes are. So they separate this into emotional health, which looks at how often are our patients using the mental health resources that we have, social functioning, peer interactions, relationship roles, health behaviors, like Dr. Jens mentioned, eating habits, physical activity, and substance use, and then cancer-related cognitive impairment, memory, attention, executive function. Depending on the age range of our AYAs, this could be in school, in careers, and in kind of their financial independence. And then in the outer setting, just the multiple levels that this distress can be seen at, whether it's the patient level, their social support network, the healthcare system, or the institutional level. So that's just a framework to keep in mind as we think about targeting studies to this population. What are we actually looking for outcomes? So moving into 2 specific areas of interest in this adolescent and young adult realm, I wanted to start with fertility. Oncofertility is actually a relatively new term over the past 20 years and really encompasses the specific care that patients with any cancer in general need to preserve their present or future reproductive capacity. Concerns related to fertility and fertility preservation are quite common in the AYA cancer population and really extend into survivorship. And in addition to what you might imagine, this also encompasses financial and insurance issues, and certainly the quality of life and social relationships of our patients. And thinking of this on a more melanoma-specific level, even though we know the risk of melanoma increases with age, it's the 3rd most common cancer diagnosis in adolescent and young adult males, and 1/3 of women are actually of childbearing age at the time of their initial melanoma diagnosis, so certainly relevant to this population. And while we have quite a bit of knowledge on the effects of chemotherapy, some of our traditional cancer therapies on fertility, pregnancy, breastfeeding, similar levels of knowledge related to some of our novel treatments, especially ones that we've learned about today, may be lacking. And really some of that existing knowledge is based on case reports or really assumptions on what we know about the drug's biological mechanisms or side effects. Throwing in quite a few graphical abstracts here, but this comes from a 2020-something article that really looks at oncofertility in the area of some of our new targeted cancer drugs. And I like it because it goes just beyond what I mentioned in terms of the biological mechanism of the drug. We also have to think about the organs affected by the tumor. What is the risk of relapse and survival outcomes for that specific cancer? Is this related to hereditary tumor symptoms? What are the patient's actual desires for family building? So again, just speaks to kind of the holistic approach that's needed for oncofertility in our melanoma patients of reproductive age. So like I mentioned, there's much to learn about the effects of melanoma treatments on fertility, but just as important really is the patient experience. So we can learn a lot from the biological mechanisms, but what do our patients want and what are they interested in? So just to highlight something that we've done at Michigan, it was really just a small study to explore the general thoughts and attitudes towards fertility, infertility risk, and fertility preservation, specifically among our adolescents and young adults. This encompassed standard instruments, so assessing fertility knowledge, fertility preservation knowledge, resource utilization, as well as interviews with the participants. And we ended up having 27 adolescents and young adults that were willing to participate in these interviews. Briefly, there were 27 patients that completed both the interviews and the knowledge assessments. And the interviews are really where we get a lot of the really rich data from our patients in a way that we're not able to fully assess in the clinical setting. The goal of the interviews was to assess what is the general cancer experience, goals for the future, including family planning, and what were the experiences with fertility preservation if that was pursued. This was a qualitative research study, so our group coded these interviews into knowledge, reproductive concerns, and information needs categories. And with that in mind, we were able to extract themes, other things that were important to our patients. It was a relatively balanced study in terms of male and female. Of the 27 patients, 17 actually elected to pursue fertility preservation. And in terms of solid tumor, non-solid tumor, 48% of our patients had solid tumor, and I believe there were 3 melanoma patients. Just to give you a sense of the kind of data and themes that came out from this study, we were able to publish multiple articles focusing on the financial burden of fertility preservation, the communication required between the young adult cancer patient and their romantic partners, and how challenging that can be. And then more to my specific interest, how fertility and fertility preservation plays into the body image distress of our young patients, which I'll build on a little bit more. And so thinking about my interest in body image overlap, fertility and fertility preservation certainly affects how people think and feel about their bodies. And it's more than just the physical discomfort. It's also thinking about the expectations of the body in terms of a reproductive capacity and failing to maybe meet those expectations, fear of judgment amongst peers or romantic partners, and just kind of appreciating the changes that the body goes through the cancer experience and the survivorship experience. On this slide, I'm going to highlight a few representative quotes that come from patients from these interviews. I think it's really important for us as clinicians that are here to see how some of our patients may speak differently in different settings than they do in the clinical setting, and I found it meaningful. So this is from one of our 23-year-old patients in the study who talks about the physical ramifications of fertility preservation, giving herself shots, something that she's never had to do before. And she actually suffered from ovarian hyperstimulation, so had a lot more physical discomfort than she expected. Another 20-year-old female talks about, the anticipating changes of the reproductive experience. She is somebody that always imagined having a family of her own. And while she'd be open to adoption or something else, it's not necessarily what she had in mind. One of our 17-year-old participants recalled an interaction that she had with the reproductive endocrine specialist. And she's like, well, they told me that this is probably the peak right now. This is when I should be having kids. And they were speaking very much more physiologically than she ever did. And then one of our male patients really spoke to what it might be like to have this discussion with a partner in the future, how challenging that might be. So going back to body image distress and kind of that overlap, 60% of adolescents and young adults with cancer, both in the treatment setting and the survivorship setting, have clinically significant body image distress. And as I mentioned, physical appearance is certainly a part of that, but it does go a bit deeper into thoughts and feelings related to how one's body functions. As you might imagine, this is developed, body image is developed in adolescence and young adulthood and really stays with you. So it's quite important in this patient population. And for many reasons, this isn't really well managed, both in the cancer setting and really at large. It's hard to address these things when we don't have good treatments or things to mitigate body image distress. We might feel uncomfortable as clinicians, and a lot of patients might feel, well, this doesn't matter, and even though it's bothering me, this isn't the time or place to bring this up. As I mentioned, managing body image distress goes certainly beyond just the cancer experience. When it's managed in other settings, it's usually as part of another overarching diagnosis, whether that's eating disorders, body dysmorphic disorder. And when it is addressed, it's with another medication or relatively intensive psychotherapy. Most of our adolescents and young adults with cancer or a history of cancer may not meet the criteria for these diagnoses. And many of our adolescents and young adults in the survivorship period are not necessarily interested in another medication or more intensive therapy, especially after they have already completed intensive cancer therapy. So these non-pharmacological interventions are desired, and that's kind of what I want to focus the remainder of my talk on. I also wanted to just kind of separate out some of our patients with melanoma and the specific challenges that they face. In one study with women with localized melanoma, 64% said that their appearance would be rated worse post-treatment, and 23% remained unsatisfied with the appearance of their surgical site. So speaking to the physical appearance aspect of body image distress. In another study that is a more qualitative study, the authors were able to find that patients with higher levels of body image distress, and these are patients with melanoma, that actually mediated relationships between cognitive illness representation, how patients thought about their illness, and family stress and psychological morbidity. This is a kind of mediating diagram and highlights that body image distress really facilitates a lot of different psychosocial supportive things, all leading to outcomes and quality of life. So what do we do about this? And kind of my last few slides will focus on one of the non-pharmacological interventions that may be helpful in this arena for our patients with melanoma suffering from body image distress. And that's expressive writing. This is a technique that's really been around since the 80s. And at its truest definition, implies that you're writing openly and honestly and deeply about emotions and experience, particularly traumatic or stressful ones. It was actually initially developed to help patients suffering from post-traumatic stress disorder. And if you recall a few slides earlier, that's not necessarily too far of a stretch to rate the cancer experience as a traumatic scenario. The first intervention with expressive writing, again, was in the 80s, where students at a university wrote about a personal trauma daily, and they found that they utilized the student health resources less frequently than those patients that wrote about neutral topics. So a very early study, but still evidence just the same. And since that time, expressive writing has been adapted to patients with cancer, and some more recent data has shown that some adult patients with breast cancer might have benefits towards sleep and quality of life overall, engaging in an expressive writing technique. So highlighting a study that was ongoing here was looking at a body image focused expressive writing intervention to help mitigate this body image distress suffered by our adolescent and young adult cancer patients who had finished their treatment. It involved 30 adolescents and young adults who had completed their treatment, and they wrote weekly for 20 minutes about a body image focused cancer related topic. And specifically looking at their body image distress and anxiety. And again, speaking about the really rich data we gained from interviews and just talking with our participants, that was part of this study as well. This was mainly to determine, is this something that our adolescents and young adults want? Is this feasible? Is this something that's acceptable to them and meets their needs? And then, of course, is it helpful? Is it actually mitigating body image distress in a way that is helpful for our patients? So briefly, for this study, there were 30 patients consented and 27 patients ultimately were randomized, and only one patient did not complete all 4 writing prompts, which was really, really good for us to see the adherence to this study. And 23 patients participated in the interviews, and 5 of these patients had melanoma. So the melanoma population was well represented in this study. Just to give you a sense of what our participants were writing about, we have the intervention and control group writing prompts. So for example, when we did our interviews, I would say that week 4 was probably the most discussed prompt amongst our participants, where they put themselves in the role of somebody else, them giving advice to somebody else who may be dealing with some of the body image distress and disturbances that they were feeling. That was a powerful prompt for our patients, compared to control groups that are writing about neutral topics. So how did it go? Recruitment went incredibly well. patients liked to participate, completed the prompts, and acceptability data was excellent. Patients really, really enjoyed doing this, and early look might be impacting body image distress and anxiety, but we shall see. Again, this is the third time I think I've said it. These qualitative interviews really do give us some really rich, deep data, and things that we learn from talking to our participants in this study is that they're interested and they would write longer, they would write more. This is something that they'd like to get more involved with. We let participants write however they chose, whether that was voice to text, pen and paper, writing on a laptop, typing on your phone. It was a really adaptable intervention. Participants were also interested in a group-based intervention, a social media-based intervention, or exploring this when they're actively on treatment rather in the survivorship setting. And then one of the research assistants working with this study has a social sciences background and really got a lot of rich data relating to the body image experience in general, and is working on delving into that a bit more. So what can patients do today that we learned from our study? What can be helpful for our adolescents and young adult patients with melanoma? A lot of our participants found that a community was really important. There are AYA support groups and there are councils as well where you can advocate for others. A lot of our adolescent and young adult participants felt that that was really empowering to help other people that are in similar situations. We also do want to know as clinicians about things like this, any psychosocial distress, things that are affecting our patients, even if it might seem minor. We may not have all the answers, but we often know people that do. And then really just writing in general, and whether it's prompted or free writing, has a lot of benefits for people in general, and certainly seems like it would be helpful for our adolescents and young adults with melanoma, both during active treatment and in the survivorship setting as well. So just to summarize, our adolescents and young adult patients with cancer in general and melanoma in particular face some really unique stage of life challenges, and a lot of these encompass the psychosocial realm. Fertility concerns are prominent amongst our AYA patients and can span multiple dimensions, and a lot is still yet to be learned, but we can learn from our patients in terms of their experience. Body image distress and anxiety can be recognized and addressed, and really future directions to expand our non-pharmacological intervention repertoire for some of these things are wanted by our patients, and learning from what our patients say to really guide our research going forward. So thanks for inviting me, and thanks to my adolescent and young adult team. That's all I have.
Thank you, Dr. Watias. That was an excellent talk. All right, so we're at the Q&A session. I have a couple questions, and I'm also going to send some of them out to my colleagues. All right, first one, Dr. Jens, would you recommend this high fiber diet even for non-melanoma skin cancer patients?
All right, I think it's working. So it has been looked at, mostly in the context of patients getting immunotherapy. So for some of the non-melanoma skin cancers, people get immunotherapy and others don't. So probably more applicable in the patient types that are getting immunotherapy. But again, probably little harm, and it's being looked at in other tumor types as well.
Thank you. Next question, you as well. My doctor has not recommended I start immunotherapy before surgery. Is there a reason that this could not be standard for all cases?
So hard to know on an individual case. The data I showed applied most to patients who have cancer in a lymph node. So sometimes patients are getting surgery when it's not in a lymph node and it's just on the skin. So that could be a reason. And sometimes if people have other medical conditions that they're nervous that might get flared up with the immunotherapy, that could be part of it as well. So hard to know.
And then the last question I have, can we speak about the change in priorities and perspective that follow a melanoma cancer diagnosis? My family and friends want me to move on, quote unquote, now that I have finished treatment, but I think and feel differently and have concerns for the future. I think we all feel strongly about that. There is no right or wrong way. I think it is always a balancing act between acceptance and engagement with your cancer diagnosis, which unfortunately doesn't stop after treatment stops, but also trying to balance that with having some kind of quote unquote normalcy in your life so that the cancer isn't all of what you think about all the time. I like to use the analogy that cancer should be your part-time job, not your full-time job. And so let some of that job go to your colleagues or your physicians. But I do feel strongly that to some degree, especially with a melanoma diagnosis, there is always something kind of there with us. But you have to figure out how to manage it. It's okay if you feel differently than your friends and family. That is okay too. I don't know if anybody else has anything to say. Your microphones are on. Okay. All right. I think we done with Q&As.
Are
Any?
there questions from the rooms? Anybody wrote it down?
Good question.
You'll need to.
Push the button and it should turn. There you go.
Screen. When you have metastatic melanoma and it's traveled to your organs, is immune therapy something you do for life? Because melanoma travels through the blood, right?
So that's a great question. There are a couple different ways of approaching it depending on which agents we pick, and we try and do treatment that is representative of the data that we have and also what is right for the individual. So many of the immunotherapies have been looked at for finite periods of time. We
For
think
what?
for specific periods of time, not indefinite.
Not indefinite.
Not necessarily. That's one of the beauties of the immunotherapy is that is the concept that there should hopefully be longer lasting consequences of adjusting the immune system. The problem is what that duration is can be different for everybody and different depending on the treatments. Many of our treatments have been studied over a period of about 2 years for more advanced melanoma. There are some studies that have looked at indefinite treatment. And when we say indefinite, we kind of say as long as it's working against the cancer and somebody isn't having unacceptable side effects. But there are many times in the immunotherapy world where we stop it after a certain period of time if we think we've hit what we call maximal benefit, right? Because the risk of side effects continues on. So that's that kind of balancing act where we want to give you what your body needs, but we don't want to expose you to higher risk if we think we've maybe maxed out what we can give benefit-wise. Any other questions from the room? All right, should we take the break?
Yeah.
All right, so we have a bit of a break. We are going to reconvene in about 20 minutes at 10:20 for our next presentation. Thank you so much. Everyone, we're going to get started for the next part of the session, please.
Yeah. Is there any other presenters from so okay.
Yeah, we're done with that. All right, so thank you for joining us for the second half of our session. It's my pleasure to introduce Tarek Hakel, who's a medical oncologist and clinical assistant professor in the Department of Medicine. He joined the University of Michigan faculty in 2024 from the Ohio State University and completed his training at Hurley Medical Center and Duke University. Dr. Hakel has a clinical focus in melanoma and Merkel cell and is passionate about uveal melanoma, which is his topic for today. His research focuses on clinical trials evaluating novel agents as well as combinatorial therapies in melanoma and other advanced skin tumors. Thank you, Dr. Hakel.
Good morning. Thank you, Dr. Fesher, for the kind introduction, and thank you for joining us today, whether in person or online. And yes, I'll be talking about a topic that I'm very passionate about, which is uveal melanoma, a very rare melanoma that we'll learn more about today. Okay. So I'll be doing a brief introduction, discussing sort of what can we do either before or after a procedure for uveal melanoma and surveillance after that, and then touching on recurrent and metastatic disease treatment. These are my disclosures. And to get us started with a brief background, we've heard already many talks from my colleagues about melanoma. And the way I describe melanoma is a cancer of the melanocytes. And these melanocytes are most commonly found on the skin and give the skin pigment, but little do people know that these melanocytes can really be in different parts of the body. And that's why we have 10 different types of melanomas. It all depends on where it starts from and how it looks under the microscope. So uveal melanoma, if you look on the left, arises from this uvea membrane, which is the membrane that sits between the retina and the sclera of the eye. It's a composite of the choroid, ciliary muscle, and iris. These are all fancy words just to kind of share the structures of what this uvea is. And unfortunately, these melanocytes there can unfortunately in rare times become malignant. And as you can see here on the right, show these tumors that are called, again, uveal melanoma in that part of the eye. So the typical symptoms that we see are kind of acute or subacute, so sudden changes in the eye, in the vision, sometimes the visual field. So sometimes people may see parts of their visual field, sometimes flashes, changes in the iris color. And sometimes, honestly, people don't have any symptoms and they just happen to have a routine eye exam and their eye doctor sees something concerning. And the way I say it is all roads lead to a really specialized eye center, because this type of melanoma is rare enough that we need highly skilled expertise to get us the diagnosis and the next steps in care. So what are the risk factors to developing a uveal melanoma? It sort of is really about the same as developing a skin melanoma. So older age, fair skin, a lot of moles or nevi, as we call them, sensitivity to sunburns, Caucasian descent, blue eyes, and other risk factors that are related to family history or other genes that we might inherit from our families. So the unique thing about uveal melanoma, as I've already alluded to, that a local ophthalmologist may be concerned about it, but then they pass the care to someone with a higher specialized expertise, and those are the onco-ophthalmologists. They're very rare individuals with really, really fine expertise. And the unique thing is that they do non-invasive testing and they look in the eye and they can diagnose uveal melanoma, which is very interesting as opposed to a lot of other melanomas or even cancers where we need a biopsy to prove the diagnosis. This cancer really tends to be diagnosed clinically. And so this is really, really unique. So uveal melanoma is the most common intraocular tumor arising from the pigmented layer of the eye, as I already shared. It is, however, the rarest form of melanomas, and its incidence is only 5 cases per million per year in the United States. Treatments initially will involve treating it in the eye once we diagnose it in the eye, right? And that is usually done largely in 2 different ways. One is take the eye out, which is called enucleation, which, as you can imagine, is a bit scary and sometimes causes a bit of disfiguration to the face, and we lose the vision and the eye, which we try to avoid if possible. Unfortunately, that's not always the case. Another way is to implement some form of radiation to the tumor within the eye. The most common way to do that is called plaque brachytherapy, which is a small plaque that gets inserted in the eye close to the tumor and emits radiation over a few days. And then it's removed after that. And that radiation that treated the lesion then takes its time to slowly shrink the tumor. Unfortunately, again, not everybody qualifies for the plaque brachytherapy for a variety of reasons. I would say the size of the tumor, the behavior of the tumor, the location, is it bleeding? Is there already a significant vision compromise? And is it invading into local structures? So all of these things can factor into the onco-ophthalmologist's decision which treatment modality is favored. Obviously, we would like to minimize the procedure done so that we can preserve vision and eye as much as possible. But again, that is all to say how much of an importance it is to get that tertiary care ocular treatments for this very rare melanoma so that people can get the proper, most advanced care and treatment. Now, despite our best efforts to treat that rare melanoma of the eye, unfortunately, when we look globally at everybody with uveal melanoma, half of our patients will develop a recurrence or metastatic disease at some point in that first decade after diagnosis. And we'll talk more about that in a second. And when that happens, when they develop distant disease, unfortunately, the prognosis becomes quite limited, and we'll also talk about that in a second. So with it being more of an aggressive form of melanoma, and with it readily going to other organs in that first 10 years after diagnosis, I always tell my patients with uveal melanoma that unfortunately everybody needs some form of a surveillance of the whole body for that first, at least for those first 10 years after diagnosis, just to make sure that if this melanoma were to recur, that we find it as early as we can. But obviously, how frequently do we surveil or monitor the body is then dictated by risk assessments that we do on the tumor itself and the patient, so that we determine the exact frequency that that patient needs in terms of surveillance. And this is sort of all this fancy table and stuff that you see. So we look into, tumor size, certain mutations, the age, and other risk factors. And our NCCN guidelines, which are the national cancer guidelines, really detail very nicely like the risks, the group risks of patients depending on those characteristics. But if you look at the bottom, I think the most important factor that plays a role in our decision-making of what is the risk of a patient of this cancer coming back is this Castle decision DX. And if you remember, although I said that we try not to biopsy the tumor to diagnose it, we tend to still take a few cells of that tumor to send for this genetic testing. And this testing is really helpful in determining the risk. So it generates a class, it generates a frame, it generates genetic mutations, and we sort of put it all together to tell the patient what their risk is at, right? And you can see, it's a bit blurred, but like you can see in the table that, for example, at class 1A, the risk is really not that bad, right? Like they're metastasis-free, meaning they can live to 3 years and even 5 years with very minimal risk of them having a recurrence or stage 4 disease. However, if you look at class 2, for example, the risk is 50% at 3 years, and majority of folks will recur at 5 years. So this kind of tells you that, for example, at class 1A, I may order imaging to surveil their body maybe once a year, as opposed to a class 2, which have a really high risk of them having a recurrence. Then I may do it every 3 to 4 months for many years. Now, despite a lot of advancements that we already have seen from prior presentations, and mostly in skin melanomas, uveal melanoma is still one of the cancers that we still do not have a whole lot of effective drug therapies against. And so right now, if a patient gets a diagnosis and treatment of uveal melanoma in the eye, we still do not have very effective preventative therapies to put them on before or after that procedure to try to improve their outcomes. And right now, if a patient is interested in trying anything to improve their outcomes, it still is within a clinical trial, right? So, and that's what Dr. Fesher had mentioned in her first presentation, these two key words, right? Clinical trials, because again, this is a very rare melanoma with very limited options. We're still in a phase of really trying anything to improve outcomes. And that's where I always encourage patients to get on a clinical trial if one is available. So to highlight the importance of a clinical trial, this is a pill called darovasertib. It's a PKC inhibitor that has shown in a very small cohort of patients with uveal melanoma that it can shrink the tumor within the eye to quite a few patients, right? So the idea was that if we can shrink the tumor in the eye, we can try to save more eyes and avoiding patients losing their eye with enucleation and maybe doing the plaque brachytherapy that I talked about to try to help them keep their eye and vision. And this pill was successful in 75% of the time to shrink that tumor and even save the eye. And this is a pill that was given up to 6 months before the procedure and maybe sometimes after. This is now moving to a phase 3 trial where the company is testing this pill up to, again, 6 months before the procedure in 2 different cohorts of patients to try to see if we can not only shrink the tumor and save more eyes and minimize side effects done to the eye from local therapies, but also seeing long-term, are we gonna improve the risk of recurrence? Are we gonna get better outcomes and survival for these patients? This is sort of a very quick look at our national guidelines for uveal melanoma. And when we look at treatment, right? And now we're gonna start shifting gear to stage 4 disease, meaning when, unfortunately, despite all of our efforts, the cancer had come back. You can see that the first 2 words is always a clinical trial. And even in the preferred regimen here on the right, you can see the first one is when available and clinically appropriate, enrollment in a clinical trial is recommended. So again, to emphasize the importance of that. But beyond the clinical trial, what do we have as far as standard drug therapies for stage 4 uveal melanomas, unfortunately, when it actually recurs and goes to distant organs? I believe somebody already mentioned tebentafusp or Kimmtrak today, but this is an intravenous drug therapy, first of its class in melanoma. So it's a bispecific antibody, which is a bit different than a lot of the immunotherapies we've already discussed this morning. But the way it works is, I think of it, it has 2 arms, right? One that captures sort of the T immune cell and one the cancer and tries to kind of force marry them to get a response. Unfortunately, it does not work for everybody because it does require that protein expression marker called HLA-A0201, which almost half of our patients have it, in order for that drug to work and engage with the immune cell. Nevertheless, it is a big celebration in the field because this is the only drug therapy that has shown a survival advantage for patients with metastatic stage 4 uveal melanoma. And this was compared to a control, which at the time used to be single agent immunotherapy or chemotherapy. Now, what if you don't have an HLA positive? Then we default into the traditional immunotherapy drugs that are used mostly for cutaneous or skin melanomas. But this is a lot of fancy figures, but I'll show you a simplified table where, again, if you have HLA positive, you tend to use tebentafusp. Median overall survival, so meaning 50% are alive almost 2 years on treatment. HLA-A*02:01 negative, they can use the most robust combination immunotherapy we have, which is ipilimumab, nivolumab, which can work, obviously less so than tebentafusp, but it is an option to consider. But above all, again, getting on a clinical trial may be the most effective thing, especially for the HLA negative patients. And newer, not so much a drug therapy that treats sort of the whole body, but a kind of interesting, sophisticated way to deliver treatment. So this is a melphalan hepatic delivery system. So uveal melanoma tends to go to the liver a lot of times. And even when it goes not just to the liver is implicated in over 95% of the time. So a lot of times we tend to treat the liver only because that could be the only site of disease for stage 4 melanoma, uveal melanomas. And this was an interesting concept where it's sort of like a surgery. So patients have to be in the OR and they go through the vasculature up to the vasculature of the liver itself only and deliver exclusively to the liver a high intensity chemotherapy. And then we filter out that blood and then give it back to the patient. This is all to say that we're treating the liver only and avoiding the rest of the body and giving back the patient the blood that is filtered from the chemo. Now, does it work for everybody? Unfortunately not. So the benefit is about 30 to 40% of the time. It's a therapy that requires 2 days of observation in the hospital after the procedure. It's done every 6 to 8 weeks, up to 6 to 8 times. And people, at least in my humble experience, tend to tolerate it okay. It's just a matter of, are they going to benefit? But again, it is a win, another win to the field where we can exclusively treat the liver for select patients that might benefit from it and hope to get some form of a response if they're in that 30 to 40%. So in summary, uveal melanoma is rare, but an aggressive form of melanoma. Despite local therapies done to the eye, a lot of patients will have a high risk of having it come back in a stage 4 disease. Multidisciplinary surveillance is important while taking into account the patient's uveal melanoma risk, kind of the genetic risk that I talked about. There are no effective standard perioperative therapies available right now, but promising drug therapies are currently under study, and enrolling in a clinical trial is very key. We have to test for HLA-A*02:01 positive once a patient is diagnosed with metastatic uveal melanoma, because that tends to be the first step in the algorithm to see what therapies work or do not work for select patients. And finally, consider, when appropriate and available, enrolling in a clinical trial and getting uveal melanoma care in a specialized center to optimize treatment options and get the optimal care needed. Thank you so much for listening, and I'm happy to take any questions.
Thank you, Dr. Hakel. So our next speaker, we cannot possibly talk about melanoma of the skin without a skin doctor. And Mike Davis is here to save the day for us. This is our dermatologist joining us. Give me one moment to make sure I get everything up. So it's my pleasure to introduce Dr. Davis. He is a clinical assistant professor in the Department of Dermatology here at the University of Michigan for 1 year now, 2024. Fantastic. He completed his dermatology residency and served as chief resident at Dartmouth Hitchcock Medical Center. He completed a fellowship in micrographic surgery and dermatologic oncology at Scripps Clinic in La Jolla, California, and he completed a cutaneous oncology clinical research fellowship at Memorial Sloan Kettering Cancer Center in New York, and was also an instructor of dermatology before arriving here. Thank you, Dr. Davis.
Hello, everyone. Thank you all for having me today. I'm really excited to be here and to represent the dermatology perspective for our fantastic multidisciplinary melanoma team, and to talk to you about what your dermatologist wants you to know. I find we see high volume patients, and I go through all of this on. Oh, you're not sure.
I apologize.
Okay, perfect. And so, I see a whole lot of patients on a regular basis, and we go through together all the things that I'm going to talk about here today, but I find that I rarely have the time and the opportunity to kind of go into detail of exactly kind of why I'm going into this, why this matters, and kind of put the emphasis on why I'm looking at this, why I'm talking about this. So I'm excited to kind of have that platform here today. To advance, there we go. And so, first off, the National Comprehensive Cancer Network, we've seen this already here today. This is a not-for-profit alliance of 33 leading cancer centers, of which the University of Michigan is one. And this group publishes clinical practice guidelines that are super helpful and practical and detailed. And I refer to these on a daily basis. I encourage our residents and medical students to always have these pulled up and to review them. And you can access these online if you make an account. They're all available there as well. And because these are so helpful and for me in organizing my thought process in my practice, I want to kind of use these as a guideline and kind of a roadmap for our discussion here. And I'd also like to point out that the chair of our department, Dr. Jakjian, is a contributor to these guidelines. And so the perception can be from some patients and even other specialties that the role of the dermatologist is exclusively in early stage melanoma. So melanoma in situ and the top layer of the skin in early kind of stage 1A melanoma. So on the diagram, that's everything on the far right. That translates to, again, melanoma only in the top layer of the skin or very superficially invasive disease. And although very early disease is very far on the small end of the spectrum here on the right, it accounts for a vast majority of new cancer melanoma diagnoses. And that's good because catching them early stage don't have a very favorable outcome. And so we in dermatology, we see these patients, we treat these patients. Ultimately, we remove these early melanomas with an appropriate rim of healthy skin in our clinic, with fortunately a very high cure rate. And generally, we own these patients, and within our clinic, they don't need necessarily our multidisciplinary management because they're such low risk disease. And so we kind of keep everything in house within dermatology there. But I just want to emphasize that we are involved in all higher stages of melanoma as well, because anyone with the diagnosis of melanoma should see a dermatologist and should have their skin checked comprehensively. And so when I'm seeing a new patient with melanoma, when I'm going through this, I have this kind of brief checklist in my mind of the kind of really important things that I'm thinking about. So I want to kind of share what I'm thinking about when I'm seeing a new patient, and starting with the history and why this is so important. So going back to our guidelines here, we know of certain risk factors for the development of melanoma. And so when I'm asking about a patient's history of skin cancers, have they had prior melanomas? Have they had basal cell or squamous cell carcinoma? Family history, any skin cancers run in the family. Where did you grow up? I'm trying to assess, your sun exposure history. Did you have multiple severe sunburns as a child, blistering sunburns? Many people can recall a, very traumatic sunburn experience early in childhood that they'll relate to me. Did you ever use tanning beds? Are you still using tanning beds? Again, I'm trying to get a sense just based on the history before I even look at your skin, just, what is your risk based on these risk factors that we know about for the development of melanoma? And again, the history is so important, but nothing is more important to me as a dermatologist than the exam, than being able to look at a full skin check, head to toe exam. I want to see, how many moles the patient has. Are we talking about 5, 10 moles, 50, over 100? These are very kind of different exams and mean different things to me. And then how do those moles look? Are they, just baseline, the average mole that this person makes? Is it a little funny? Is it a little atypical? Because that can be okay in that patient if they have 50 slightly atypical moles that all look the same. We're trying to look for any sort of outlier that really doesn't fit the background pattern. I'm trying to get a sense of what is the background sun damage, how, despite you're telling me your history of sunburns or sun exposure, how has your skin responded to that? How healthy does your background skin look? And if there are any spots of concern, I want to make sure I biopsy them. And if they're originally diagnosed melanoma, for which they were sent to my clinic, if there's still any residual clinical lesion there, I want to make sure that I biopsy that in a process called microstaging, so we make sure that we have all the information necessary to go down these different pathways and make sure we're treating the right disease. And I want to check any, lymph nodes, make sure there's nothing swollen there, anything concerning there as well. That being said, there's wide variability in practice in the techniques of a full skin check. There's no rule, there's no distinct right or wrong way to do this. I mean, how many people in this room have had a skin exam? So most hands here. And if you've ever had a skin exam from different providers, you might think that they look very different. And sometimes I get that concern, either even about my skin exam or about someone else. Well, that's not how my prior doctor looked at my skin. I have, some folks go head to toe, some go kind of front to back. I had one colleague, one of my mentors, who started on the left side and went down and back around because she didn't want to go back and forth across the exam table multiple times, and just thought it was the most efficient route. So again, there's no right or wrong, as long as we're looking at everything. So that's kind of our goal. And the studies show we do this day in and day out, and in order to not miss anything, to make sure that we're being comprehensive, the goal is really to also try to do it in the same way possible every time. If you do it the same way, you don't deviate from that, and you're being thorough and comprehensive. Now, that being said, I think a lot of people can be surprised at how fast this process can be. I've also seen patients who've seen other providers, and they've kind of expressed concern. My dermatologist, they barely glanced at me, and hopefully that's not true. Hopefully they were very detailed oriented. But how long do you think a skin exam should take for someone to look you over comprehensively, head to toe? 20 minutes. Yeah, I think when I started residency, I was asked that question too, and I threw out a number, maybe not quite 20, maybe 10 minutes is kind of my guess. And people have looked at this, and kind of this can be anywhere really like 2 to 6 minutes. And again, there's no rule. That's really going to depend on a patient's skin. Again, for a patient who has over 100 melanoma, or sorry, not 100 moles, 100 moles, that's going to be a longer process, really trying to fish anything out. In this one study, I quoted up here, it was just under 4 minutes on average. And so it can be fast if there's not much that we're concerned about. We're trained heavily in this pattern recognition, and seeing kind of the things that jump out to us are often not the things that jump out to patients, I think is the concern there. So, and the other point I'd like to highlight is when we say full skin exam, we're really advocating, we're really pushing for a full skin exam. Of course, disrobe to the level of your comfort, but the less is better, and please know makeup is also very helpful. And when you see your dermatologist, sometimes inquire into their practices, because sometimes there are these rules or guidelines that, if a patient has disrobed to the level of their comfort and they've left on their socks, if they've left on their underwear, that's their way of telling you they don't want you to look in those areas. So just kind of being mindful of that kind of, and maybe knowing, what you want to examine, what you're comfortable having examined, and knowing that we're ready and we're there for you. And why is this important? We've looked at this. This is a survey study from dermatologists and their practice patterns concerning concealed sites, I think was the term that they used. And this is dermatologists self-reporting on how often they examine these areas. And you can see here in the anogenital areas, over 20% of the time we're just never checking there. If or occasionally maybe, but that's the vast majority of patients not having thorough exams in those areas. Breast, oral mucosa, and scalp. I think that we can certainly do better with this, but the other thing is they looked at the factors that determine, when do dermatologists check these areas, and the leading thing in most of these instances was patient concern. And so this goes back to kind of getting to know your own skin and kind of advocating for yourself. If you have a concern, addressing it, asking for someone to examine an area, asking about a concern, because we know that kind of drives up the rate of kind of thorough checks there. And so going back again, my checklist for kind of what I'm thinking about then, these for patients with new diagnosis of melanoma, I want to make sure we set aside some time to go through the pathology report in detail. Because this is highly confusing. There's a lot of information here, and I think this generates a lot of confusion, at least in my clinic. In this day and age, wonderfully, patients have immediate access to their pathology reports, which is great on so many levels, but also comes with some problems because this is difficult to interpret. For example, there's this Clark's level, which is 1, 2, 3, 4, 5, refers to how deep the melanoma was in the skin, and I often have patients kind of coming in focusing on that. They locked in on that. They're saying, this is Clark's level 4. I have stage 4 cancer, and it's highly anxiety inducing. But we make sure we kind of spend some time walking through this in detail and trying to make sure that we understand what this is telling us, where we got this information, because this is really what directs our care. And going back to, I asked all those questions on our history. We're working right now to make sure that we're sending appropriate patients, maybe more patients, to our genetics colleagues to see if there's a role for a genetic specialist in the care of patients if they meet certain criteria. Going back to our guidelines, here is a kind of a blown up version of this, which is essentially if there's a family or personal history of 2 or more invasive cutaneous melanomas, or family history of at least 2 non-cutaneous cancers. There's some particular ones that have more import than others, but so we kind of review these risk factors, these personal risk factors. We see if they meet criteria, and then not everyone who does meet those criteria goes and ends up seeing a genetic specialist. It all comes back to we talk about also the potential benefits of that, and how would this affect things for you? Would it affect things for you? Is this something that you would want to know? And so we place a referral if desired and appropriate. And then I want to make sure that I talk. The not insignificant portion of this is on patient education. I think this is incredibly important. I generally try to end visit with reminders about melanoma and sun protection. So these might be the famous ABCDEs of melanoma. I repeat this innumerable times a day. But again, telling patients what to look out for. We are hopefully doing our job, seeing and checking skin on a regular basis, but things can change between those visits, and it's important for patients to also be taking a look at their skin, bringing their concerns to their dermatologist, and if there is a spot in these concealed areas, that we make sure that we're addressing it. So ABCDEs of melanoma, this only applies to moles and melanoma. This is where we get into some trouble. There are a lot of benign skin spots, seborrheic keratoses, wisdom spots that can break a lot of these rules. And they're allowed to break the rules because they're not moles, they're not melanoma. So that can be really tricky, and we're not expecting you to kind of hone in on that and be able to tell the difference. But for moles, A being asymmetry, where one half doesn't match the other. If you were to fold that spot in half, it won't line up. Borders, where the borders are irregular, jagged, it's hard to tell where they start and stop. Colors, the C is colors, so color variegation, multiple colors within the same spot, only within the same spot. So you can see this photo here has some dark browns, some light browns, even some pinks kind of coming into that edge there. And D is diameter, so spots larger than 6 millimeters, I say approximately the size of a pencil eraser. And then E is evolving or changing. If I could encourage patients on one, it's really that E, because ideally these are patients who've had melanoma. They're plugged into the system. They're being seen regularly. So hopefully when you leave your skin check, you know that everything right then and there looks okay. And so if anything is changing, anything is evolving, between that visit and your next visit, that's what you really need to look out for. And then, this is a whole lot of information at a visit. I'm aware of that. So you can always kind of boil this down into this kind of ugly duckling sign. If you ever just have a spot that doesn't look like your others, let us know. Let us know you're worried about that. And so what else, I like to emphasize, when are you actually exposed to the sun? We worry about the UV radiation causing changes in moles and melanoma. And so, of course, sunny days, you have exposure to UVA and UVB light that kind of comes through and can cause photoaging and skin damage and these changes that we're worried about. But I think it's important to know that even on cloudy, even rainy days, UVA is still kind of passing through those clouds and that rain. UVB is partially blocked, but still kind of passing through as well. So even if it's a cloudy, rainy day, important to be wearing your sun protection there too. UVA passes through most glass. UVB is partially blocked there. And car windshields usually having a little extra protection there. But if your job is sitting right next to a bright window all day, that's something to be aware of too. And just because you're inside or driving in the car doesn't mean you don't have to wear your sunscreen as well. And then lots of surfaces reflect the UV rays as well. So snow certainly is reflecting a large percentage of that. Bright snowy winter day there, 90%. Of the radiations reflected right back up, and water reflects a decent amount, sand, and even some dark soils too. So always important to kind of be aware of that. Please avoid indoor tanning. That's a big thing for us. We try to emphasize that. I think, at least in my practice, I've been seeing less of that in recent, which is a good trend, but we still do see it. And if I could beg any one thing, is to avoid that if for this specific purpose for melanoma risk reduction. Seek shade, avoid the peak sun exposure hours, if you can, 10 to 4 a.m. If you're training for a triathlon, if you're a cyclist, get out early, take the last tea time if you can, and late in the evening, and of course wear your sun protection. So what does that look like? So sunscreens, they shield you from UVA and UVB radiation. They come in different forms. The minerals or sunscreens are usually the zinc and titanium. They're getting better, but can be it's hard to rub in, leave a white cast, but they work really well and they're very effective and very safe. I think all the sunscreens that are FDA approved are very safe, to be clear, but I think that if there's ever concern, usually steer people towards this direction. A lot of our baby sunscreens contain minerals. The chemicals tend to rub in a little bit better, be a little bit maybe more elegant, and again, we think they're very safe. And I always like to point out when people bring up concerns, it's safe, and the alternative of the UV radiation, well, we know that's not great either. So I think the sunscreens are very safe and important there. When picking out a sunscreen, look for something that's broad spectrum. That means that it protects against UVA and UVB rays. And SPF, it refers to the amount of protection from sunburn, and it's kind of an interesting number there. So how you use that is if it takes you on average 10 minutes of direct sunlight to burn without sunscreen, it actually takes 30 times that. That's what the SPF 30 means, to burn if you're appropriately wearing SPF 30. And so the curve really falls off sharply above 30 if used appropriately. So again, I think 30 or higher is appropriate. You don't need necessarily the 50, 70, 100, with the caveat of if you're using enough. It's kind of linearly graphed there. So if you're really not using enough sunscreen, just using a little bit, you're using a quarter as much sunscreen as you're supposed to, then you're really only getting usually a quarter of the benefits. So for those folks, I'll try to, maybe 70 is the right number for you if you're, just using a little bit there. And then water resistance just refers to, how long it can maintain SPF protection, usually either kind of 40 or 80 minutes during kind of water exposure. Apply your sunscreen, before you go outdoors, 15, 20 minutes. The spray sunscreens can be very convenient, but they should really be rubbed in. I think we see, probably all know someone who's got a burn where they use their spray sunscreen, they have this very nice protected spray line, and then burned everywhere else. So after spraying that on, make sure you take a moment and rub that in. And going back to how much sunscreen you be using, it's a lot. So generally 1 ounce, 2 tablespoons, a shot glass full for kind of all skin surfaces. So if you're not covering everything, you don't need that much, but that's a lot of sunscreen, and it should take you a little while to rub it in fully. And of course, reapplying if you've been out for a long time, or if you've been sweating, exercising, toweling off. And don't forget your special areas, eyes, lips, feet, these areas that maybe aren't as convenient. Hats, very, very important. This never really comes from 4 inches of wide brim. We'll take it. We'll take whatever we can get. The larger, the better. And I think that's kind of, larger hats are coming back in now, which we're excited about. And the tight weave for both hats and clothing can be helpful. So, no holes. And then there's this UPF kind of clothing that's becoming more common now, which is this kind of, it's been tested. What is the UPF protective factor of clothing? And so I think that's less important. Not every article of clothing needs a UPF score. If you're wearing a big thick hoodie, well, that's going to protect you really well. But we know that thin white cotton t-shirts have very, very little protection. So if you're looking for something in the summer when you're fishing, when you're golfing, that's really lightweight, that you're not going to get hot in, these can be very helpful because they're often very lightweight, but they've been appropriately tested for their sun protection. And then, as I said earlier, just being your own advocate and taking a look at your own skin. Often that requires using some mirrors, 1 or 2 to get a little creative, or having someone else look at your back for you, these hard to see places. But, again, bringing your own concerns to your dermatologist. And I think this comes up a lot and causes a lot of unease with patients. And it's just, how often should patients be seen? And I think that's a little hard. It's a little vague. We don't have really good hard evidence on that usually for melanoma site 2, I think for most folks without really significant other risk factors, a year is very appropriate. Some patients will do more frequent, 6 months to a year, but I think anything less than 6 months is, without any other high risk factors, is maybe not necessary, at least for most patients there. 6 months to a year for early stage disease, and then more frequently the more concerning the melanoma there. And essentially, why is this important? So the risk of having a second melanoma at the time of a first melanoma is about 0.5 percentage point. And patients who've had a melanoma are increased risk of developing a second new melanoma. Of course, there's the risk of the recurrence from the original melanoma. We want to catch as early as possible if that's the case, but we're also looking for any new melanomas there. So that risk is about 5–10%. And that risk of subsequent melanomas seems to be rising too. Just want to emphasize one other point here. This is a different role of dermatology that I think is really exciting, and this is not something that I directly practice, but is becoming much more and more common, more sought after. A lot of academic centers, I think, are building these departments and these divisions here right now, and that's oncodermatology. And so this refers to the dermatologic management of conditions that develop in relation to cancer treatments. You've heard some about these wonderful medications, these immune checkpoint inhibitor therapies that really kind of take the brakes off the immune system, help fight cancer, which is so fantastic. But a lot of things in dermatology, when you take the brakes off the immune system, when you ramp up the immune system, you can see that in the skin. We think of all these inflammatory conditions in the skin, these itching conditions, rashes. It's all the immune system being a little overactive in the skin. And so this can really affect patients' comfort, quality of life, and their treatment. And so this specialty is really designed to help patients with that, recognize these things early, treat these things early, because immune-related cutaneous, so immune-related adverse events or events in the skin are the most common side effect of these medications and generally occur very early in the process. So it's important to kind of catch those and treat those appropriately. And so the goal is to manage the symptoms and hopefully, appropriately keep people comfortable, and thus allow patients to continue their really important cancer therapy if appropriate. And we have our team here. So Dr. Renati here is involved with this, as many of our residents as well. So thank you all for your time. Again, it's just a brief whirlwind of what I want you to know at least. So thank you all.
Thank you so much. All right, our next speaker is Dr. Chi, who is a medical oncologist and a clinical instructor in the Department of Medicine. She has joined us in the past year as well, or actually a little over a year now. And so she is in both the divisions of hemonc and geriatric medicine here at Michigan. Her clinical focus is melanoma and Merkel cell, and her research interest includes communication, improving communication between clinicians, patients, and caregivers, and early discussion of advanced directives and equitable care for older adults. And I will also say, I think she wins the award for the most creative title for her speech today. Thank you.
Hi, everyone.
Oh,
Stop it. I'm so honored to be here. Like Dr. Fesher was saying, I'm a geriatric oncologist, meaning I get to take care of older adults living with cancer. I often say I'm a little obsessed with how to make difficult conversations a little bit easier. The title of this talk, which thank you so much for letting me win, actually comes from one of my patients who took a look at the label on my white coat and said, "Ugh, don't call me geriatric. I'm not actually geriatric." And that moment really stuck with me. It reminded me how much stigma actually surrounds aging and how often older adults with cancer face a lot of unfair assumptions about what they can or cannot handle. Today, I want to share how we can rethink our care for older patients with cancer, especially in melanoma, and how even small changes can make a big difference in people's lives. So I'll start by highlighting some of the unique challenges that our older patients face in cancer care and what both physicians and patients should keep in mind when treatment begins. Then I'll explain what geriatric oncology actually is and how it helps us think about care a little differently. And finally, we'll go over some of those tough but important questions that I think we should all be asking. So let's start with a story. It's a true story based on one of my patients. She's a 93-year-old with melanoma. Her primary care doctor actually noticed a small spot on her back that started growing quickly over a few months. Staging scans revealed a surprise. The melanoma had spread to her lungs. As you can imagine, she was shocked. How could this have happened? And what should she do next? What makes sense for her? Sorry. How do I? Yeah, I just realized. Okay. Thank you so much. Thanks. So this is something that I think we all implicitly understand in this room. We're seeing more and more cancer diagnoses amongst older adults. As people live longer, more cancers are being detected in those 65 and older. In fact, the American Cancer Society predicts that by 2030, nearly 70% of cancer cases will be in folks over the age of 65. That means our healthcare system has to and needs to evolve to meet the needs of our older patients. You know, many of my patients don't just have cancer. They also have things like heart disease, diabetes, memory changes. Some of them are facing chronic fatigue or increasing falls. And all of this affects how they might tolerate treatment and how they recover from treatment. A lot of older patients don't tend to mention this to their oncologists. I've had patients actually tell me, like, you handle my melanoma, my Merkel cell. I have other doctors that handle the rest of my problems. But, in reality, a lot of these things, energy, mobility, and memory, really play a huge role in how someone does during treatment. So that's where geriatric oncology comes in. It bridges cancer care with whole person care. And there's another challenge in our older adults. The group most affected by cancer is most often left out of the research that guides how we treat it. They're underrepresented in clinical trials, so doctors often had to make treatment decisions without enough data for what actually works best for them. This chart shows the proportion of older adults enrolled in trials compared to how many actually have cancer in the real world. And you can see there's a big big gap across a lot of cancers. Sometimes this happens because of bias, assumptions that we make that older adults are too frail or won't tolerate treatments. Other times it's because those trials have excluded people with multiple health conditions. As a geriatrician, I really do believe that ageism, prejudice based on age, might be one of the last seemingly socially acceptable biases in medicine. Even before we meet a patient, some people might make assumptions based just on the number, on the date of birth in their chart. So here's a photo that I really love. This is Faujah Singh. He ran multiple marathons until he retired at the age of 112 years old. So, people like him really remind me that age doesn't define what someone can do. Our job isn't to assume, it's to ask, listen, and to tailor care to fit each person's goals. As a geriatrician and an oncologist, I find myself balancing these goals very often. Oncology focuses on treating disease and extending life, where geriatrics focuses more on maintaining independence, function, and quality of life. Geriatric oncology helps navigate both, bringing longevity and quality of life in a very patient-centered way. As we age, we tend to develop more of what we call geriatric syndrome. So things like decreased physical function, falls, memory changes, these can all affect how someone handles treatment. And again, many of these patients don't mention them to their oncologist, but they truly matter to our patients, both in their day-to-day, and it also affects how we sometimes think about their overall treatment. That's why geriatric oncology focuses on the whole picture, cancer care that includes the rest of you too. A key tool that we often use is something called a comprehensive geriatric assessment. It's not a complicated test, but it does take time. But it is simply a structured way to think about your whole body health and your generalized health. So it includes things like physical strength and daily function, medications. If you have more than 5 medications, that sometimes triggers us to try to minimize how many medications you're on. It includes things like mood, nutrition, comorbidities or your other existing medical conditions. It includes things like social supports and cognition or memory or how we're thinking. So by checking in on these areas, we can uncover things that labs and testing might not necessarily pick up. Things like low mood, balance issues, or medication side effects that we can try to mitigate before we start treatment. Even better, once we identify those things, we can act on them. So we can connect patients if they're having more falls, we can connect them to physical therapists. If we're noticing that there are signs of malnutrition, we can hook them up with our nutritionist. And if there's signs of what we call polypharmacy or too many medications in the mix, we can try to cut those down. There's also powerful tools and calculators that can actually help us numerically predict the risk of side effects with things like chemotherapy. So it's a very powerful thing that helps us reduce treatment side effects overall, helps us keep patients independent and in their own homes, and ensure that the care that they're receiving really matches their goals. What does it look like in real life? One model is a consultative clinic. So this is where oncologists trained in geriatrics like myself work alongside nurses, pharmacists, therapists, and social workers to complete this full geriatric assessment. It's still pretty rare for now, but hopefully in the future, less rare. And I'm hoping to establish something similar in years to come at the University of Michigan. There are other models too, like oncology clinics where team members are trained in geriatrics and can do screening tests, things like assessments for mood and for cognition. And then there's my own model, which is a disease-specific geriatric oncologist, where I use kind of a shortened version of the comprehensive geriatric assessment called the practical geri assessment. So it's a shorter version, still takes about 30 to 60 minutes, but it still gives us a lot of helpful insights. So we can return to my 93-year-old patient with melanoma. Based on that age alone, some people might have assumed that she was too old for treatment. But when I met her, she was sharp, independent, and still gardening every day. She had strong family supports as well. Through her geriatric assessment, I learned what mattered most to her, staying active and seeing her great-grandchild graduate from high school. Together, we chose a treatment that balanced effectiveness with tolerability, single agent pembrolizumab, if you care to know. And after her first infusion, I still remember I called her a couple of days. She was, one of the first patients that I had treated. I called her 2 days afterwards, and she said, "Dr. Chi, I am raking leaves right now. You are interrupting me right now." And I think, and even better, her scans later did show that she was responding to treatment. And I really think this story highlights the power of treating the person, not the age. As we wrap up, I do want to talk about what I call the hard questions. These are the important conversations about the future. Things like prognosis, medical care preferences, and values around care. Most patients actually want to know their prognosis, but very few remember actually discussing this with their oncologist. And I get it. These are really tough topics. Doctors, we want to strike this balance of giving hope, also being realistic. But by avoiding some of these questions, it actually can leave patients and families very unprepared. And that's where this concept of advanced directives comes in. These are written documents that you probably have heard of that let your healthcare team know what kind of care you want. Or not want, actually, if you are ever too sick to speak for yourself. So they let you name a person who can help you make decisions on your behalf. And I want to emphasize that planning ahead isn't giving up hope. It's really about empowering you to make the decisions that make sense for you. It ensures that your care reflects your wishes, not just your illness. And that's why I'm actually developing a short screening tool, which is just really 4 quick questions to help doctors start these conversations in a really, hopefully, gentle manner. It's not about paperwork. It's really about opening the door to meaningful conversation. So here's my 4 questions that you can ask yourself and you can ask your oncologist. Have you discussed the goals of your treatments? Have you talked about your prognosis? Do you have someone who knows your preferences for care? And have you written those preferences down? From there, you can really start thinking about what's most important to you, who you trust to make medical decisions, and how you want your care to look like in the future. I've thrown this up. This is a really great resource. We also have like paper handouts too that I think are really, really excellent. But this is one in case you don't have access to our clinic. This is called Prepare for Your Care, and it really walks you and your family members, the people who should be making these decisions, through these steps in very easy to understand language. Called Prepare for Your Care. And I think the website is prepareforyourcare.com. But don't quote me on that. Maybe just Google it. So in summary, I hope I've shared some of the unique challenges that our older patients face in cancer care and show how geriatric oncology can really help us provide care that's compassionate, evidence-based, and centered in what matters most to you. If you're able, think about asking some of those questions to your oncologist if you haven't already. Think about your treatment goals and preferences for medical care in the context of your melanoma. And yes, if this seems like an approach that appeals to you, please let your oncologist that it might be appropriate for you to see me in my geriatric oncology clinic, or to see a geriatric oncologist near you to help navigate some of these really challenging conversations. Thank you.
Thank you so much, Dr. Chi. All right, our final presentation. You stole my introduction. Thank you. Tasha, who knows what I would say? I just make it up. So our last speaker is Dr. Tasha Hughes. She is one of our surgeons here in the melanoma group. So Tasha is a surgical oncologist. She is also a clinical associate professor in the Department of Surgery here at U of M. And she also serves as the associate chair of the department. She completed her residency at Rush University and her surgical oncology fellowship at the Ohio State University and joined U of M in 2018. Her research focuses on health services, specifically healthcare safety and quality and provider communication and bias. And she treats melanoma, Merkel cell, as well as breast cancer. And she joins us from another event for her other tumor.
Sure. No, I'm kidding.
Oh.
I ask for steps in the operating room all the time,
I
but
don't think you need a step here. We're a petite group.
okay. All right, very good. Good morning, everyone. It's nice to see some familiar faces. As you heard, my name is Tasha Hughes. I'm a surgeon in the Department of Surgery. And today I'm going to be talking about melanoma surgery today and really why our operations are getting smaller. And I think we're right in the middle of this journey, so it's an exciting time to talk about it. I have no financial disclosures, and I actually talk about sort of de-escalation of surgical care across a lot of diseases and often joke that actually this is very disincentivized for me because I'm going to talk about doing less of what I do. So the general topics to be covered today is a little bit of background about how melanoma surgery used to be done. I'm not going to go back lots of decades, but in the past, what has changed and why, the big trials that got us to where we are today and the trials that are gonna get us to where we are tomorrow, and really what it means for patients. This is an exciting opportunity for me to get to give a talk that is patient facing as opposed to doctor facing. So I'm excited to be here, and I'm also really happy to acknowledge the familiar faces that I see in the room. So it's nice to see you guys. So just a little bit of background. I think this is not unknown to anyone. As we all know, melanoma is a skin cancer. You've been hearing about it all morning and have been impacted by it. And it can and does metastasize. So I often start my encounters in the office with just that fact. And it's that actually drives a lot of the surgical stuff that we're going to be talking about. Lymph nodes are filter stations. And one of the most common questions I get in the operating room is, what do lymph nodes do? And do I need the ones that you're about to remove? They're filter stations and they filter cancer. They're often thought of as kind of barometers about whether to tell us whether or not cancer has spread, but they may serve some other roles to actually prevent it from spreading further. And then the surgeries that you'll hear about today, wide local excision obviously is removal of the skin cancer with a rim of tissue around it. Sentinel lymph node biopsy is removal of the first couple of draining lymph nodes in a given lymph node basin. And then completion lymph node dissection is the general term to describe removal of all lymph nodes within a single basin. So what's the big picture? This is the 10,000-foot view. So surgical de-escalation. This is something that we are talking about a lot in melanoma right now. It's something we talk about all the time in other disease sites. So some of my colleagues in surgery and I always say, when there's the same signal in every cancer type, it's a good signal. This is a real signal. This is a real direction we're moving. So past, present, and future. So what was melanoma surgery like before? Well, big is the answer. I think that I often tell my patients in the office, and some of you, I'm sorry if you've heard some of these little one-liners before, but I often tell my patients for a long time, really up until the early 2000s, the treatment for melanoma was surgery and prayer. That's what we did. We took it out and we kind of hoped for the best. There weren't great therapies. Things have changed so much, and there are a lot more options now. So this included big surgeries at the primary site, but even more importantly, big surgeries at the lymph node site. So removal of all lymph nodes was very, very standard up until the early 90s. In the early 90s, the concept of sentinel lymph node biopsy was introduced in melanoma. So melanoma was sort of the original, the OG, as my kids would tell me. Sentinel lymph node biopsy allowed us to remove fewer lymph nodes and moved us that was the first, I'm not going to talk about that a lot today, but that was the first big sort of de-escalation, if you will. Now move towards smaller targeted operations when safe that have fewer side effects and the same survival for most patients. And it's important to know that what I'm talking about today, this is not just based on us wanting to do less. That is a sentiment that comes up sometimes. We don't want to do less. I love operating. I love the operating room. Those are my good days on my weeks. And so I enjoy what I do, but I think that I don't enjoy causing people harm that doesn't help them. So first, the first area of de-escalation, there are going to be kind of a couple of these different areas, is avoiding that completion lymph node dissection. Oops, I hit the wrong arrow, sorry. So the big turning point here is a study that we talk about. I think earlier, Dr. Davis said he says the ABCDEs like 1,000 times a day in his clinic. I'd say MSLT2 1,000 times a day in my clinic. So this is our big study. This was a study that was published in 2017. So in the pretty recent past, I think about this a lot because I started in practice in 2018. I was a fellow in surgical oncology when this was published. This is like what I know. This is the practice of melanoma. And so what did this study look at? It looked at patients who had a lymph node found on sentinel lymph node biopsy that had melanoma in it, which we call a positive sentinel node. And it took patients that had that positive sentinel node and randomized this, so this was a randomized controlled trial, and compared completion lymph node dissection with no completion lymph node dissection, but with close observation. And the result of MSLT2, as was published, is that the patients who had completion lymph node dissection done immediately after their positive sentinel node had no improvement in melanoma-specific survival. So melanoma-specific survival is survival, meaning dying from melanoma. So it takes into account if something else got you. And it also showed on the flip side, because that's one really important outcome, it did show that in patients who we avoided completion lymph node dissection in, that the rate of lymph node recurrence was higher. It also showed that the patients who had completion lymph node dissection had 4 times the lymphedema rate of those that did not. So not insignificant. And what did this change? I would say maybe not quite overnight, but pretty quickly, this changed the practice. And if you look at the practice here at Michigan for patients with a positive sentinel node, it's like humming along. And then in 2017, it goes like this. And it drops. And the number of completion lymph node dissections that we did drop by about 70% in that first year and has continued to drop since then. I always am remiss to say, I feel it's like a very America-centric way to only talk about MSLT2. MSLT2 is not the only study to have done this. And in fact, the DCOG SLT study is more or less exactly the same study. It was done in Germany. It was actually done first. And so they actually published their first results. So their sort of 3-year-ish follow-up in 2016, the year before MSLT2, and then they published their longer-term follow-up in 2019. Again, taking patients with a positive sentinel node, giving completion versus not completing the lymph node dissection, and comparing survival, and again, found no survival benefit. The impact of this is probably wider international adoption of this practice. Again, I also think just like when you have 2 signals going in the same direction, it just helps give confidence in how the study was done and the meaning of the results. So those are the 2 real landmark studies that have impacted many patients over the last 8 to 10 years. What does avoiding completion lymph node dissection mean? Well, fewer complications, I think, is the big one. So we like to focus a lot on the fewer complications. So lower risk of lymphedema. Again, in MSLT2, the rate of lymphedema in patients who had completion dissection is 24%, and it's 6% in those that didn't, so 4 times different. There's more to, particularly in the underarm, there is more to complications than just lymphedema, motor and sensory nerve dysfunction, which is true. I mean, the reality is the lymph nodes live with the arteries, veins, and nerves that travel all throughout your body. The lymphatics run right with them. So removing them has impact on some of those other structures. What does it also mean for patients? Well, it means probably more follow-up, close follow-up with regular exams, not just physical exams, but ultrasounds and CT scans. And then avoiding completion lymph node dissection, it's sort of something that we talk about a lot on the, sort of in the workroom between patients, is that these studies, MSLT2 and DCOG, were done at a time when immunotherapy was really in a very, very nascent, if that, stage. And so the trials around immunotherapy, which you heard about earlier in the day, were kind of happening at the same time. But there are options for systemic therapy, even in those patients who haven't had dissection. what's the next frontier? So I'm excited to talk about this. The next frontier in lymph node management is this is kind of being described and studied in this clinical trial, which is called the Excellent trial. I think it's every time I write an email to one of these guys about it, I change the spelling because I think I don't have it right. So I just write it a little bit different every time. But anyway, excellent is how you're supposed to say it. This is a clinical trial that's actually going a little bit further, and it's taking patients who have a palpable or identified node, either palpable or identified on a CT scan or an ultrasound, just one node, so a single node. And it's this kind of trial is called a pragmatic clinical trial, which is super interesting. And the real, like the simple way to think about a pragmatic trial is rather than a patient enters in and then you get randomized, which causes some angst for a lot of people. I think the concept of being randomized in a study is nerve-wracking for a lot of patients. The way that a pragmatic trial works is it actually seeks to sort of sit in and lay over standard care, the care that you're already getting with your providers. And so this trial takes patients who have that single involved node, and there are kind of two main cohorts. It can be that we remove the node, just the one, not all of them, just the one. And then you either can get therapy with immunotherapy or not, depending on what your decision is with your provider. That's one option. The other option is if you are found to have a single node, we can do the neoadjuvant strategy where you get the immunotherapy first. We remove just the one node and then watch afterwards. So it avoids the bigger lymph node surgery and just targets the measurable disease. This is a clinical trial that's currently open here at Michigan. It wasn't written. I feel like a lot of times when I'm talking to patients about it, I always want to emphasize this isn't like me moving forward my academic anything. I have nothing to do with that. Actually, it doesn't benefit my academic development at all. This is a study that was designed elsewhere, but we are a site. We're excited to enroll. We just enrolled another patient yesterday, actually. So really, if effective and shown to be equivalent survival and outcomes could really open another door to avoid lymph node dissections in another subset of patients. All right, I'm going to move on now. So we're going to move on to reevaluating the role even of sentinel lymph node biopsies. So this is sort of another horizon, if you will. So sentinel lymph node biopsy, as I think a lot of people in this room may know, sentinel lymph node biopsy is that sampling of those first draining nodes. The traditional anchor is that sentinel lymph node biopsy should be done for patients with 1.0 millimeter or thicker melanoma, which we call T2A or more. And it should be discussed for T1B melanomas. So those NCCN guidelines that Dr. Davis brought up earlier, that's kind of summarizing what they say. And so that area, the discussed for T1B, I think is an area that has kind of growing conversation about the value of sentinel lymph node biopsy. And you might be saying like, well, especially if you had one and it was really like smooth and easy and you had no issues from that, like, why does it matter? Maybe just do it. The reality is that 80 to 90% of the sentinel lymph node biopsies that we do, if you look at these thinner melanomas, are negative. And so do we need to be doing them in everyone? And we want to avoid unnecessary procedures. And as I often find myself saying, my goal as a surgeon is to not be just removing lymph nodes just to see if there's cancer when I really don't think there will be cancer there. So we're trying to avoid some of these. So I'm going to introduce the concept of the Merlin test, which is new. This is pretty new, I would say, but we are using it. It is live and approved out there in the world. So the Merlin test is a non-invasive, it's a gene expression test. So it basically takes the tissue from the tumor, which is obtained by your biopsy, and runs sort of a genetic evaluation of a couple of genes within the tumor itself, and gives a score, a risk score, high risk and low risk. It's binary, so it's just two possibilities. And what we know, and what has been now recently published through the Merlin group, is that this test can help us in patients with these thinner melanomas, so certainly T1B or 0.8 and 0.9, but also T2A melanomas, to further help us characterize, okay, so these patients are generally low risk. Can we further tease out low risk and high or low risk, and make a decision about sentinel lymph node based on that. This concept of applying a genomic test is not new. I've been doing this. The best parallel I can think of is a test called Oncotype in breast cancer. We've been using Oncotype as standard of care for decades. So this concept of this type of test is not new, but in melanoma, I would argue it is new and it's exciting. So the prospective data suggests that Merlin can reduce sentinel lymph node biopsies, particularly in T1B and T2A melanoma patients. So just a little bit more about the data that has informed Merlin. This was based on a large multi-site national, international even, but certainly national study that applied this Merlin assay and sort of built this Merlin assay using tissue from real patients. Michigan was a very large enroller into that sort of validation study. It does represent head and neck melanoma as well within the Merlin study. And the bottom line for patients is that by building this, we were able to identify that there is a sort of a risk score where the risk of sentinel lymph node biopsy can be sort of downgraded for these thin melanomas. I think I said all that. Sorry, I forgot I had another slide. Shrinking margins. So this is the next frontier. This is moving away from lymph nodes. So now talking about the actual removal, that wide local excision that I mentioned. I tell my patients very frequently that the data for informing how big of margins that we take, while very well established in the NCCN guidelines and something that we all have adhered to kind of without question for a long time. Actually, the data that informs the margins is based on like many different small, mostly single institution studies. And it's all patchwork together. And they've looked at 1 centimeter and 2 centimeters and 4 centimeters when we used to do that back in, I don't know, before I was a doctor, so a long time ago. I don't know, like a long time ago. And so it's sort of this like patchwork amalgam of where we think that the right margin size comes from. And there's some statistical power behind it, but there's never been prospective data to really tell us what the right margin is. And like I said, before immunotherapy, there was a little bit less desire to sort of be more precise in how we did those margins, because this was it, right? Like you got to do your best surgery, and that's what there was. And so now that there are options and there are treatments available, I think it is a good time to say, well, how much big primary surgery do we need to be doing? So there are 2 trials. They're like friends, MELMART and MELMART 2. So these are basically asking that for thicker melanomas that we have traditionally decided upon a 2 centimeter margin, can we do a 1 centimeter margin instead? And again, when I think about the signal across many cancer types, the concept that the primary removal of the tumor need only be completely removing, not completely removing, plus a bunch of other tissue. I think that's a general trend across many cancer types. That's really kind of what we're talking about here. So MELMART was the feasibility trial, and then MELMART 2, which is the clinical trial, phase 3 randomized controlled trial of 1 centimeter versus 2 centimeter margins for patients with 2 millimeter or thicker melanomas, essentially are entered in and randomized. So this is something where you get put into a computer generator and then we do what we do. What I always tell my patients who were motivated to go on this study were very motivated to try and get the 1 centimeter. And they would often say to me, well, what if I get randomized to 2? Can I just have the 1? And unfortunately, I can't do that because it's not the standard. So, but you would get randomized to one or the other. We don't have results yet. The trial is closed. It just closed about a month ago because it reached the accrual goal. So we no longer are enrolling for that study, but we're excited to see the results. Wrap up. Okay, I've gotten to the end. So those are my big things. So why less surgery? I think the thing that I talk about with my patients and that we all talk about in groups of doctors talking about this is that survival is always going to depend more on the biology and early detection of recurrence than on just removing lots of tissue and lots of nodes up front. I think we have within some of these clinical trials, we have good guidance on how to carefully watch people on surveillance using ultrasounds and cross-sectional imaging or CT scans, as well as physical exam. And we can catch treatable nodal recurrences where it's not too late. And of course, the addition of modern systemic therapies that work. which is great. They're really the heroes, the medical oncologists. And so, so what can you expect today? Smaller incisions and fewer drains. In many cases, fewer skin grafts, I would say. Lower risks of arm swelling or lymphedema, especially when avoiding completion lymph node dissection and potentially in the future avoiding more sentinel lymph node biopsies. Clearer plans. I think we've come really far just in the 7.5 years that I've been here in sort of the coordination of how we survey patients or watch patients. And that's really super important. And a lot more shared decision making. I'll always tell people this isn't making my job any faster in the clinic. That's for sure. There are a lot more options than when I started in 2018, where I could do that melanoma talk in like 8 minutes at the beginning because there were not very many choices. And now there are. Great. I think that's it. Thank you guys so much.
Thank you, Dr. Hughes. All right. Well, we were going to take a few minutes to let Ann Garst-Taylor from AIM at Melanoma join and share some information about patient resources.
Thank you.
Yes.
Over there for Eric to fuss at. So, first of all, thank you so much to all of our panelists. What wonderful presentations, right? It's so filled with hope. There's so much hope. I am Ann Garst-Taylor. I'm with AIM at Melanoma. I'm their Director of Community Engagement. Thank you for a few moments to talk about our foundation. I do want to say that we are planning 20 to 30 minutes of questions afterwards. It's not too late to get your questions in. If you will, though, if you'll write them down, my wonderful volunteer, Sue, will you raise your hand? She will grab your questions if you've written down questions, and we're going to get to as many as we can. If we can't get to those today, I will nab the ones that we don't answer. I'm going to talk a little bit about a program that we have called Talk to a Medical Expert, and we'll do what we can to try to make sure that your questions are answered, but we'll do the best we can. So AIM at Melanoma is a foundation that was founded 21 years ago by Val Guild, if you don't know our origin story, after her daughter Charlie was diagnosed with melanoma at the age of 25. Unfortunately, Charlie did not respond to the only FDA-approved treatment that was available to her at that time. And after she died, Val formed AIM at Melanoma with two missions. The first one is to find a cure for melanoma in our lifetime. And there are two things that AIM does that are unique that I want to make sure that you know about. The first is that she founded the International Melanoma Working Group, which is a by-invitation meeting twice a year from researchers all across the globe. So they have an opportunity to share their achievements and their challenges as we move closer to a cure. And the second thing is a set of 5 tissue banks across the country that are collecting fresh frozen primary tissue. It took a long time to set them up, and we now have about 250 samples. When we get to the point where we feel like we have a diverse enough group of samples to offer to researchers, we're going to begin doing that. The second thing that Val wanted to do is to make sure that people who were going through a melanoma journey were thoroughly supported. And a lot of that comes from education. And so I want to talk to you about our website, the things that are available there, and everything that I'm about to talk about is available at no cost to the community. So I'm sorry, I'm a people person rather than technical. So they're going to help me here. There, no, yes, there we go. So our website, by far the most frequently visited pages have to do with staging, the related treatment, side effects, side effect management, and clinical trials. Another frequently used service is our Talk to a Medical or Ask a Medical Expert service. Melissa Wilson is a PA. She works with Dr. John Kirkwood at UPMC. And she will ask the questions that you forgot to ask when you got your precious few minutes in clinic. Now, this is not for the purpose of changing your plan of care, but, was there one question about a diagnostic test that you forgot to ask? Or did you forget to ask, why am I getting a PET scan instead of an MRI? The kinds of questions that come up over and over and over again. And as a result of doing that, providing that service for individuals that visit our website over the course of the years, she started a webinar series called From the Clinic to the Living Room. So these are the most frequently asked questions that Melissa gets, and so there they are for you in case you have questions that that you struggled, things that you're struggling to understand. The other thing that we have on our website are these symposiums. AIM at Melanoma co-hosts 10 a year all across the country. And so I want to kind of explain to you what we've done. So today, obviously, we've hosted a live seminar, and we've had people that have visited both in person and also have viewed the symposium live. What we are doing is we're recording that symposium, and it will be available within about 10 minutes on our YouTube live station. And so following this symposium, what I will do is I will send an email out to anyone who registered for the symposium, and I'll send the link to YouTube so that you can watch it again or that you can share it with family and friends. I've gotten a couple questions about whether or not the slides from today's symposium will be available, and that is how you will be able to see this information again and stop it and get the information that you need. AIM at Melanoma also has a podcast called Beyond the Clinic, and it's hosted by Dr. Sam Siegel. She is the director of survival medicine at KP in San Francisco. She herself is a cancer survivor. She believes in vitality from the moment of diagnosis. And the thrust of this particular podcast is the emotional impact of a cancer diagnosis, the isolation that people can experience, the fears, the depression that they feel, those kinds of things. And how do they move to a position of vitality where they feel like they are moving through their treatment in a positive way? The other thing that we think is very important on our website is a section for caregivers. We know that you are involved in a lot of the important decisions that are being made as you go along. You are the scribes when you go to clinic. You're the researchers. And so we have a section of our website dedicated to you, but we also want you to take care of yourself. So please visit that section. And then last, I want to talk to you about Peer Connect. Peer Connect is a one-on-one mentorship program. We have 62 individuals who are melanoma survivors who have gone through a training program, and their goal is to serve as a support, a sense of encouragement and inspiration to people who are still going through melanoma treatment. If you feel like that what you'd like to do, we certainly hope that you have a large circle of trust, people who are supporting you while you go through treatment. But if you'd like to add somebody to that circle, somebody who understands thoroughly what you've gone through, then reach out to me, please, and I'll be happy to connect you to a mentor. So if I can help you, if I can navigate our website for you, if I can help you find any of these patient resources, if you'd like to know, have we done webinars or symposiums on other topics, then reach out to me, please, and I'll help you navigate our website and find some of the resources that we have there. The other thing I want to ask you to do is a favor for me. Inside of the patient packets that you have here today, there is a survey. I'd like you to ask you, please, will you fill that out for me? Because that asks you, what kind of content should we be supplying at these symposiums so that moving in the future, we'll, all be sure and produce material that's important to you in your journey. And with that, I'm going to turn back over to Dr. Fetcher.
Thank you, Anne. All right, question time. So one, I'm going to turn on all of the table microphones. Don't be too excited. So you certainly can push the button. Thank you. And when the light turns green, that means your microphone's live. So I have several questions here from the audience, but we also can take questions from the live audience if you would like. Anyone? Or I'll start reading. Okay. First question was for, I'm going to be your resident dermatologist because Dr. Davis cannot join us back that was terrible English. I apologize. Come back to join us. What products do you suggest for sun protection spray versus lotion? I think he answered that already. I think I always say the best sunscreen is the one that you're actually going to use and reapply on a regular basis. Spray is okay, but it's not perfume. Please rub it in. There's also a question for Dr. Davis about what is a lymph node exam with a dermatologist? What happens? How many areas? I think we can certainly extrapolate from our lymph node exams. Typically, you're going to be examining kind of the typical nodal basin. So we think of them in the neck, in the front, and the sides, right above these collarbone areas, in the armpits, and in the groin. There are other areas as well that can be involved. Sometimes they hide behind the knees or behind the elbows, but for the most part, we think of at the very least the neck, the armpit, and the groin. Dr. Hakel, I have a question for you. Thank you. The melanoma in my eye has not spread to my body. Removing my eye would be devastating to me, but would my chances of survival improve it if I take it out now?
Yeah, that's always a question I get. Oh, it turned off. Okay. That's always a question I get. As far as we know, the data does not suggest that whether we take the eye out completely or if we treat it like with the radiation that I mentioned, that it shows any difference in outcomes, at least long-term for recurrence or developing stage 4. That's why the hope is always to de-escalate surgery and preserve the eye and the vision while not compromising someone's outcomes as far as, again, developing stage 4. Going in and out. Developing stage 4 or recurrence.
Thank you. There is a question about skin exams are being done visually. Are there computer-assisted skin exams? I am not an expert at all the details of this, but yes, there are assistive devices, but at the end of the day, human beings are still a critical component to that. And as of right now, there is no way to diagnose a melanoma without a biopsy. There's certainly indicative things and a lot of interesting tools, including dermatoscopes that are used that are suggestive, but the ultimate gold standard is a biopsy. I am going to give Dr. Hakel another question. Can you get uveal melanoma from melanomas from lymph nodes? So I'm not sure if that means maybe either spread to the eye if it's gone to lymph nodes or lymph nodes involved after eye melanomas. Maybe answer both ways.
Okay. So the melanoma of the eye is strictly a melanoma that starts in the eye itself. It's not a melanoma that started elsewhere and traveled to the eye. Now, is there a correlation between getting a melanoma of the eye and other types of melanomas? Yes. That's why part of the surveillance that I suggest for patients with an uveal or eye melanoma is to also monitor for other melanomas. So that's why I always suggest to partner with a dermatologist to get full body skin checks, kind of like how our dermatology colleagues had alluded to earlier. I'm not sure if that answered the question.
I think it did. Thank you.
Okay.
I'm going to share some questions with friends out in the audience as well. Dr. Jens, do you and your team use any prognostic tools to help manage melanoma patients similar to what was mentioned for the gene expression profiling for eye melanomas?
So we don't, compared to the eye melanomas, which does that very nice table that Dr. Hakel presented, we don't have a similar thing in metastatic melanoma. There are some. There are some tools from the group in Australia that have, and generally in stage 3 disease, but a little bit less in terms of prognostic scoring in stage 4.
Thank you. I think I also want to highlight, I think Dr. Hughes already kind of spoke to this a little bit with her presentation, and that there are prognostic tools being used, I think, increasingly. And there is some variation amongst the different institutions of who uses what and what those prognostic tools are. Wearing sunglasses, does that help prevent uveal melanoma? And what kind of sunglasses would you recommend?
Okay, I guess uveal melanoma is popular. So I guess when we think of sun protection, we think of protecting the whole body, not just the skin. So definitely using UV protective sunglasses is always recommended. I don't know, patients always ask me this, like, are they regulated? I don't think it is. Obviously, if you go to Walgreens and pick up this $5 sunglass, is not going to be probably UV protective. Unfortunately, those ones tend to be a bit more expensive and likely not covered with insurance. But so I guess sun protection goes again beyond just applying sunscreen. It's seeking shade, hats, putting again UV protective sunglasses, putting UV protective clothing. Even sometimes in the cars, right? We use UV shields for patients who are sensitive to the UV light. Does it protect from uveal melanoma? I'm not certain that I have data readily in my mind. Obviously, this is something I can look into to see if there's a direct correlation between sun exposure and developing uveal melanoma. But in a general sense of rule, everybody should be seeking sun protection irrespective. Like, whether that decreases the chances or not, I think this is something we should still do to protect our bodies from melanoma or other skin cancers.
I'm going to add to what Dr. Hakel said. I think it's always a little tricky in the medical world to prove beyond a shadow of a doubt true cause-effect relationships. So we often are very careful in our language when we say, does this cause this? That has to meet a certain level of criteria. I think we certainly, as he said, the risk factors for eye melanoma certainly go along with certain risk factors that correlate with ultraviolet light exposure too, such as the light-colored eyes. But I think in general, absolutely, the recommendation is for sun protection of all parts of your body, including your eyes. Speaking of that, another question that says, with rigorous use of sun protection, should melanoma patients supplement with vitamin D3? I think that's an excellent question. I'm happy to have my colleagues contribute too. Vitamin D has been something recommended kind of across the board. Values have changed in how we measure vitamin D levels. There's many people who say, depending on where you live, we shouldn't even bother checking vitamin D levels, just take your supplement. And supplements are reasonable, somewhere between 1,000 to 5,000 international units per day. I personally think the data for like the bigger doses once a week are a bit lacking in my opinion. So I typically think of the daily dosing, but I think that's not unreasonable. I would just at least exercise some caution. Keep in mind that supplements and vitamins are not necessarily required for many individuals, and really talking with your doctors about what is recommended for you individually would be the best recommendation. Dr. Chi, Dr. Watayas, what advice do you have about nutrition, exercise, and weight management post-treatment? I know a lot of patients end up with weight gain from steroids.
Oh, it's on. Hot mic. I probably have a very different answer from Dr. Watayas, just because as a geriatrician, I love weight gain. I love a little bit of, I always call it a buffer prior to treatment, just because we do worry about loss of appetite with some of these treatments. So I do kind of love, some buffer of weight. That being said, when I talk to people, I actually, because of Dr. Jens's talk, I do actually recommend a lot of fiber for folks, and then otherwise I just tell people to eat whatever gives them joy, because life is short, but hopefully not too short.
Yeah, I think that the kind of very different spectrum for some of our adolescent and young adult patients. We know that there is an increased risk of metabolic syndrome for patients in the survivorship period, and that spans across all types of cancer. So actually weight management is incredibly important, and it's challenging depending on where maybe surgical procedures may have happened to get back to the same physical activity that you may have been doing before. I also think, because my talk focused a lot on psychosocial distress, that can actually be helpful. Oh, sorry. So I think it's incredibly important because as we hope that many of our adolescent and young adult cancer survivors, we hope that their lives are very long and that these risks of metabolic syndrome and cardiovascular effects become very real. So getting into a exercise program, one that's regulated, and talking with the nutritionist even after the survivor, like as you enter the survivorship period, I think is important. Like Dr. Fetcher said, it's not a full-time diagnosis, but that cancer history is still a part of you and informs exercise and nutrition going forward.
Thank you. I'm gonna ask if anybody in the live audience has any questions, or I'll continue reading the ones I have. Okay. No takers, no takers. Is it possible for a treatment is working even if a metastasis occurred while on the treatment? Dr. Jens?
So hard one to answer on a general level because every patient's story is different, every patient's scan is different, and so I think it depends a bit on kind of the time and course of all of that happening. So I think it's a metastasis appearing is a flicker that something more could happen more in the future. So that's what we never know when we see just one show up. And then we can be in a hard spot of, is this just the first of many, or is this truly one area that just was not responding to treatment? I think one area that sometimes we treat and keep going with our other therapy is the brain. So we know our treatments don't get into the brain as well as the rest of the body. And so sometimes if we feel like we have very good body control, but just a small change in a brain, we may radiate the brain and keep going in the rest of the body. But yes, everyone's journey is different. I've had people where it's one spot shows up and it is just the tip of the iceberg. I've had others where one spot showed up and we removed that spot and no spots ever came back. So hard to answer overall, but always good to talk with your doctor about kind of all those different pathways and what makes most sense for you.
Thank you, Dr. Jens. I think, I'm not sure if this is along the same lines, but there's a question about if I have a mole that is fading, would that be suspicious for something like melanoma? I think that is also a really individualized and difficult thing to answer. That would be a different conversation if it was somebody who already has an advanced melanoma diagnosis and is on active treatment versus somebody with no known history of melanoma and is having some changes. I guess the other question that comes to mind is it really a mole that's fading, or could it be some other kind of skin spot, which can be difficult to figure out? So the number one thing I would say is being evaluated in person by a dermatologist would be then the recommendation for that. Dr. Jens, I'm coming back to you. Is melanoma of the head and neck more aggressive or more likely to recur than in other parts of the body?
I wouldn't say it's more aggressive or more likely to come back. I think the thing we think about it differently is the surgeries to treat or cure melanoma in the head and neck can be more, have the potential to be more cosmetically altering than a melanoma on the leg or the arm. And so sometimes those surgical discussions are more intense or may involve multiple surgeons, an ear, nose, and throat doctor, a plastic surgeon, a dermatologist. And so not necessarily more aggressive, but sometimes more tricky surgical management based on the location.
And then the last two, and I think this was already spoken to a little bit by Dr. Amaria, but are some of the new treatments like TIL or RP1 therapies effective for all forms of melanoma? Specifically, are they effective in the bone? I think when we think of the different forms of melanoma, we tend to think along the lines of where did the original tumor start? It does matter where it spreads to. So I'm going to say from a bone standpoint, we think of that as the spread as opposed to where the melanoma would have started. So we tend to divide things up according to skin melanomas, mucosal melanomas, uveal melanomas, and then there are subsets within that and a few others besides that. With the sites of different metastases, there is certain variation in how different parts of the body respond to our treatments and how responsive they are. Traditionally, certain parts of the body, like the brain or the liver, and sometimes the bone, have been a little bit trickier to get responses out of, as opposed to melanoma that has spread to lymph nodes or the skin or the lung. That being said, I think there are lots of variations in how things present. So as we do, I think, better evaluations, more screening MRIs, right? We're catching brain involvement when it is without symptoms much earlier than we used to if we had to wait until somebody developed symptoms, or our scans are much better detailed, more detailed than they used to be. So we find very tiny spots these days that can be treated. And then I think the last question I have for us is, there's a new report that some of you may have seen about potential impact of the mRNA COVID vaccine on patients receiving immunotherapy. And so I think I'm going to harken back to what we just said about, we're very cautious with our words and we get really excited about preliminary evidence, but I will say this is preliminary, but very interesting. I think for many of us, this makes sense, right? So if we go back to the concept of, we talk about inflamed and non-inflamed tumors. I think you guys heard that throughout some of the talks today. Inflamed basically means, is it kind of, immunologically stimulated? Is it an environment that is activated, where we hope then that there's something for the immune cells to react to? And maybe we could do that not just by doing things like intratumoral injections to inflame the tumors, but maybe things separate, like an mRNA vaccine. It's a little interesting if we say that this is targeting COVID as opposed to something that we think is maybe directly cancer related. But again, the human body is a very unique and interesting enterprise, I think is the right word. And so that doesn't surprise us. Some of the inflammatory states I think we all saw in the COVID pandemic, at least for me, are highly reminiscent of some of the inflammatory states we see with immunotherapy. So I think it's interesting. It is what we call retrospective data. So something has happened and now we're going backwards and looking in time to say, well, can we draw correlations? In the medical world, we like to see prospective data. So if we randomized people or did something to evaluate COVID vaccines and immunotherapy and then measured things moving forward, that potentially might be something to think about. And then I think somebody's confused. I got to go green. So that's okay. I will give it air. And then Anne has a question for her. Oh, we have
Okay. Well, so there was a question from the audience about AIM at Melanoma's association with other cancer foundations. Our president, Sam Guild, is watching live. Hello, Sam. And she wanted to respond to that. And this is what she said. Yes, AIM is an international organization that works with multiple foundations. For example, in the US, we just recently led an effort to write an open letter to the FDA, encouraging them to maintain the integrity of our clinical trials. Outside the US, for example, we work with patient advocacy groups in Europe, Latin America, etc., to help patients with melanoma get access to treatment options. We also share information about organizations that can support patients in areas of financial support, housing, transportation, etc. These same organizations share information about AIM with the people that they serve. So we want you to know that this is a collaborative effort, of course. And the very last question is for me. And this was the question: is the parking free today for those of us who came? And the answer is yes, it is. That little voucher that came out of the machine, as long as you leave by 1, when you put it in the machine, the arm will lift. Okay, anything else?
So I just would like to wrap up with a quick thank you. I want to thank everyone for joining us. So first and foremost, everybody who came here in person, thank you so much. Those of you who are virtual and online, thank you so much. This is what we're here for. So thank you, thank you. I want to thank all of my speakers. They were fantastic and could not have done it without them. I want to thank AIM at Melanoma for co-hosting with us. And then I have to thank our team in the back, the hidden people who have made this happen. Sarah, Tina, Heather, Cindy, Mary Beth, and Judy, and our honorary melanoma member, Justin, our IT expert. Thank you, everyone.
Thank you for